house officers who at the moment is a cardiothoracic surgeon in George Washington University, Dr. Fazad Najam. He wrote a book on, cardiac and thoracic robotic surgery. And he dedicated that book in my name. So I'm very pleased that we have a cardiac surgeon with us today in the Asif with us. So I think it will be a great occasion to actually, join together and put in some. I'll just be joining you as a learner. I like to just learn what's going on and enhance my knowledge. Thank you very much.
Thank you very much for being so humble. And I think it's always, we're all learning and all of us learn. And I think it always fascinates me as an endocrine consultant or as an endocrinologist. We have no direct contact with the organs that we treat, and therefore I think it's a great advantage that the pulmonologists have that little window to go into the organ that is so important for them and that it treats. So I think it's always good to see how people work in different specialties, and makes me feel a little bit inadequate when I see that everybody else can do it, like Athar as a gastroenterologist can do it, and you as a hepatobiliary surgeon can do it. But I don't know what the patient's thyroid or adrenal looks like when I'm treating it, but we have imaging, but it's not the same. So I think, as you said, that robotics and all that advancement that is coming through is great, and starting in Pakistan is so great. So without further ado, I would like to introduce the president of the Pakistan Chest Society, Professor Jawad Khalid Ansari, who's been very kind and is here. He's helped many important.
Hello, assalamu alaikum, everyone. Am I audible?
Yes, we can hear you. Yes.
Okay. Everybody is hearing my voice?
Yes.
That's okay?
Thank you.
Okay. Right. Thank you very much. I think what I understand from Professor Khalid told me that it is the activity of King Edward Alumni Association of UK. And it is, I'm very grateful to you for the association and those who actually arranged this seminar, the webinar for Pakistani audience. The topic is extremely important, as you know, and we know that it is very well managed in UK. But as a practicing pulmonologist, I know how difficult it is. Whether it is transudative persistent effusion, whether it is complicated bacterial effusion, and whether it is malignant effusion, we often fall short of perfect management. So I would like to appreciate and I would like to convey my gratitude to all the speakers who are going to speak on these important topics. I hope the whole webinar will go good and we will benefit from it. Thank you very much.
Great. Thank you very much, everybody. And I think we wanted to keep everything on time. So I think we will start with our first session, and I would like to introduce the chairs of our first session. So our first chair is Professor Dr. Saadia Ashraf. Dr. Saadia Ashraf is a professor and head of pulmonology department, Khyber Medical College and Teaching Hospital, Medical Teaching Institute, Peshawar. She's also deputy editor, Pakistan Journal of Chest Medicine, editor Journal of Medical Sciences. My second chair will be Dr. Badar Ganaie, who is a consultant colleague, respiratory at University Hospital of North Midlands, Stoke-on-Trent, and has a special interest in pleural disease and lung cancer. I will ask my both chairs that they can take the session from here and introduce their speakers. Thank you. They can unmute themselves as well.
Thank you, Ashraf. So I'll start the first session, inshallah. Thank you. It's a great honor for me to be chairing this session. We have great speakers and a great topic. So without further ado, I'll introduce Professor Rahman, who is a professor of respiratory medicine and lead for pleural diseases and director of the Oxford Respiratory Trials Unit in University of Oxford, Churchill Hospital, Oxford, and he's the Deputy National CRN Lead for Respiratory Diseases and IHR CRN. He's led on numerous trials in pleural disease in the last 10 years, and may I say that he's revolutionized pleural medicine all over the world. So it's a great honor introducing Rahman. So without further ado, over to you, Naj.
Jazakallah khair, Badar, and assalamu alaikum, everyone. It's a real honor to be here. I should thank KEMCA and the organizers, the chair people, and also I'd like to extend specific thanks to Beenish, who's my current fellow who involved me in this. Thank you very much. I'll just try and share my screen And let's just make sure that you can all see that. You're seeing that okay?
Yeah, we can see that much.
Okay, perfect. Thank you. So I will talk about today the approach to bacterial pleural infection. I've been very specific in saying bacterial. I'm not going to cover TB. That's largely because all of you on this call have far more experience in TB than I do. We see very little TB in the UK, so I won't wander into areas where you're more expert than I am. So this will be in bacterial pleural infection. And the overview of my talk will address simple things such as accurate diagnosis, what the causative microbiology are, and therefore what antibiotics we should be using. Can we predict outcome? And then thinking a little bit about our options for invasive treatment options. So hopefully an evidence-based approach to the entire area of pleural infection. This is where I live. I hasten to add, this is not my garden and this is not my house. This is the University of Oxford, and it's a very blessed place to be. It's a good place to be. We love our ancient history here, being Oxford physicians, and I'll start with a little bit of ancient history. So Guillaume de Puytren, he is famous, of course, from describing many issues in liver disease, such as Dupuytren's contracture in those who consume too much alcohol. Why am I showing a picture of him? Because he acquired a pleural infection, and he said this: "I would rather die at the hand of God than at the hand of a surgeon." So he, in fact, refused surgery for his pleural infection. He then went on to die of progressive sepsis. And to give balance to this great figure, we'll give another great figure, and that's Sir William Osler. He is obviously known as the father of modern medicine. In the flu pandemic of 1915, 1916, he acquired a pleural infection, and he said the following: "Empyema needs the cold steel of a surgeon rather than some fool of a physician," by which I think he's describing me and Mohammed Tufail. He had surgery and then he died of surgical complications. So for many, many years, we have debated what the correct management is in these patients, and hopefully I will cover some of these issues as we go through. So effusions from pleural infection, we'll talk a bit about the epidemiology. This is what they look like. I'm aware that not everybody's a pulmonologist on this call or a thoracic surgeon. Septated effusion in association with some parenchymal shadowing, very typical on a CT scan, typical cavitating consolidation, and then an area of pleural infection. And this is a thoracoscopy of a patient with mid-stage empyema, so purulent pleural fluid and lots of fibrinous adhesion. So this is a great challenge to treat. And our treatment, of course, is based on two great principles. The first is correct antimicrobial therapy, and the second I would summarize as source control. So we could call that drainage of the infected material. That can escalate from intercostal tube drainage done by the physician or the radiologist, adjunctive therapies through the chest tube, such as fibrinolytics, which we'll talk about, and then finally surgical debridement and management. And indeed, there have been moves forward, especially in adjunctive therapies and in the modern use of VATS, as our kind surgical colleague talked about a little earlier. Now, early diagnosis is key, and we'll therefore address that a little bit. We will go on to talk about antimicrobials and source control there afterwards. And just so that we're all on the same page, there is this scheme in our heads of how pleural infection develops. So on the right-hand side here, I've shown you 3 different ultrasound images, and this is how we think pleural infection develops. So we have a pneumonia. There is then an exudative pleural effusion. This is associated with a simple effusion, which is not very inflammatory. There's no bacterial invasion, and that is reflected in the ultrasound finding here. So a very clear, bland-looking effusion next to consolidated lung, but no septations, nothing interesting going on. Over time, this becomes fibrino-purulent, and therefore there is bacterial invasion. There is depression of the normal fibrinolytic activity within the pleural space. You therefore have the formation of these septations, and here you can see agitated saline not moving between the different areas. Now, if we undertreat the patient or the patient receives no treatment, they end up with the organizing phase. And this is where there is thick collagen deposited, not very much fluid, and an inelastic pleural peel, and potentially a great deal of chronic infection. Now, physicianly interventions have a lot to do with stage 1 and stage 2. By the time the patient is at stage 3, the only meaningful intervention at this point is surgery. And I really won't talk about these patients any further because that's really a surgical talk. And in association with the different stages is different recognized biochemistry within the pleural fluid. So within the exudative phase, we have normal pleural pH, normal glucose, or low LDH. as we start to get bacterial invasion, the pH goes down, the glucose goes down, and the LDH goes high with some degree of culture positivity. And then, as I've said, in the organizing phase, there's usually very little in terms of pleural fluid. How big a problem is this? Well, I've combined UK and USA data here. We know that there are 1.5 million episodes of pneumonia per year, at least there were 10 years ago. And about 40% of these have an associated parapneumonic effusion, which is a huge burden of disease. So over 500,000 cases per year. These are new cases, incident cases per year in the UK and USA. Now, of those, the minority, about 15%, are frankly infected. So the majority are at stage 1 and will resolve with simple antibiotics and good general clinical care, but that still leaves about 80,000 new cases per year. So this is a disease with a high amount of burden. And this burden is increasing. So I won't spend a great deal of time on epidemiology, but these are 3 papers all published in North America, well, 1 from Canada and 2 from North America, all of them showing exactly the same thing, and that is that the incidence of pleural infection is rising. Now, why is it rising? We don't know, but most worryingly, it appears to be rising in the oldest age group. So here the boxes represent patients over 65. There was a very modest increase in the amount of pediatric pleural infection, but the great increase is in those over 65 who, of course, have the worst outcomes as well. So this is a very worrying finding. And some groups have started to ask the question, why has this occurred? And one particular theory, which I'd like to share with you, comes from this group, and this is colleagues from Bristol here in the UK, Nick Maskell and David Arnold. They did a similar piece of epidemiology in the UK, much more modern data, demonstrating that the median age and the median length of stay over the period that they looked at was about the same, about 2 weeks or so. So this remains a highly morbid disease. And if you look here, the amount of mortality remains about the same, anywhere between 13 and about 50%. And the amount of surgery required also is pretty much unchanged between 2008 and 2017. So we're really not making progress in this disease entity. And this is what they found in terms of the incidence, the same pattern. So the patients over the age of 60 have a vast increase between 2008 and 2017 in the incidence of pleural infection. Now, their theory was that this was related to influenza, and they projected this, suggesting here in red is the incidence of empyema by season, and in blue is the incidence of influenza. And they made the theory that there appears to be some association between the peaks of influenza and the peaks of pleural infection, coming up with the theory that the virus somehow damages the lung and makes it more likely to acquire bacterial pleural infection. This is absolutely not proven as yet. There aren't good PCR or virology studies that confirm that patients with pleural infection often have influenza, but it's certainly an area that's to be investigated in the near future. And the problem is not just that this disease entity is increasing in incidence. The outcomes, as I've described, are very poor indeed. 2 weeks in hospital, surgical rate of 15%, more than 35% in high risk groups, and the mortality around 15% is unchanged in the last 40 years now, we could say. So we need to do much better in this patient group. So let's start at the beginning. How do we diagnose pleural infection? Well, this is well known. This is from the BTS 2010 guideline. And in this guideline, we take patients who have pleural effusion in the context of infection. We sample the fluid, now always under ultrasound guidance in the UK, and we divide them into 3 distinct categories. The first is frank pus. That's a macroscopic diagnosis made by your eye. If you have pus, then this is empyema. This requires intercostal drainage. The second category is microbiology positivity, and any microbiology in there is pathogenic, and therefore that's confirmed pleural infection. That requires intercostal drainage. What we're left with then in the middle category is non-purulent, non-micropositive fluid, and in here we rest upon the biochemistry, and we have therefore focused on this idea of a low pH being a complicated parapneumonic effusion, as on the left, and a high pH being a simple parapneumonic effusion, with these patients tending to resolve without recourse to drainage, whereas those less than 7.2 generally need drainage. And our practice around the world is built on this one paper. This was published by Hefner, who was a pulmonologist in the USA, quite a famous man. He did this wonderful meta-analysis some years ago, looking at the predictive ability of a pH of less than 7.2 for predicting a complicated clinical course. So this did not predict radiological complexity, septation, loculation. It predicted the need for chest tube drainage, intensive care stay, or surgery. And in fact, in this analysis, there was only about 20 events. So all of us have based our practice on a really very small study. It's a pretty good marker, as you can see here from the ROC analysis, very little white area in the top left. But as you will all know, it is not 100% sensitive. And we are still all reliant on data from 30 years ago in our modern practice. So the question is, can we be more biological? Can we do better than this? And it seems that we have started to scratch the surface of this possibility. So this again from my colleagues in Bristol, David Arnold and Nick Maskell. They looked at SUPAR. Now, SUPAR is soluble urokinase plasminogen activator receptor. So a complex name, but simply put, it's an indicator of the degree of fibrinolytic activity within the pleural space. So rather than pH, which is very generic, SUPAR directly addresses the biological pathway that we are interested in if we are to believe the normal biological evolution of pleural infection. And they found something very interesting. So in this slide, I'll just explain slightly. On the y-axis is the pleural fluid SUPAR level, and on the x-axis is the pH. And they've plotted each patient according to their SUPAR and pH level, and then divided patients according to radiologically whether they had loculation or non-loculation. And what you can see is there was a spread of pHs here and no association between the pH spread and whether the patient was loculated or non-loculated, whereas the SUPAR level was extremely associated with loculation or non-loculation. So SUPAR appears to predict something more than just pH. And indeed, when they conducted the same ROC analysis, it would appear that SUPAR has a better ROC curve than pH or glucose or LDH. It indeed also predicted whether a chest tube was used in each patient's case. Now, there is a problem in this analysis, which is maybe SUPAR is just a very expensive form of pH, but nonetheless, it does feel to be more biologically plausible, and therefore this is an area that we need to understand better and take forward. Now, I'll just describe a bit of work done from one of my fellows, Ihab Badawi, who's about to publish this data. He looked at PI1. Now, PI1 is plasminogen activator inhibitor, and it's an inhibitor of the normal plasminogen or fibrinolytic activity in 240 patients with pleural infection. And what he showed is there was a very good correlation between low PI levels and non-septation and higher PI levels and septation. And for the first time, he demonstrated a dose effect, so to speak. So if we divided patients into non-mild, moderate, and heavy septation, there was a near linear association with the amount of PI1. And most excitingly, perhaps, he demonstrated for the first time that PI1 is associated with survival. So here, this is the Kaplan-Meier survival of these 240 patients over 1 year. And you can see that if you had PI1 high, meaning you were highly suppressed, your survival was only about 30% at 1 year, whereas if you were PI1 low, your survival was more like 10% at, 90% at 1 year. And again, we are perhaps reaching slightly into the biological plausibility and a different mechanism. So at the moment we use pH, but in the future, maybe we will use something that's a bit more nuanced than pH. So let's step forward into microbiology. Obviously, this is a microbial disease. What causes pleural infection? Well, this is data from the MIST-1 study. This is Nick Maskell's work from 2005, and this remains the largest conventional microbiology study in the literature. And in this study, they divided patients into community-acquired disease in the UK and hospital-acquired disease. There's a few important things to notice. The first is that this is not the same microbiology as you would expect from pneumonia alone. So this is a different microbiological diagnosis to pneumonia that's just gone bad. It's a different population. How do I know that? Because strep pneumoniae causes about 1 in 4 cases of pleural infection, whereas this group, the Milleri group, as it used to be called, or the anginosus group, causes nearly 1/4 of cases. And this is an unknown organism in conventional bacterial pneumonia. Milleri is a normal commensal within dental caries, for example. Anaerobes made up 1 in 5 cases, and there were several other things like Staph aureus and so on, which you wouldn't expect at such high levels in bacterial pneumonia. If we look at hospital-acquired disease, this is old data, nearly 20 years old now, so 1 in 4 cases of hospital-acquired disease was MRSA. I don't think that would be true now with modern infection control strategy, but about 2/3 of other cases were due to resistant gram-negatives, so they are very distinct diseases requiring very different sorts of antibiotic cover. And our major problem here is that around 40%, nearly 50% in fact, of all samples from pleural infection are microbiology negative throughout the treatment course of the patient, which can be up to 6 weeks, as you know. And therefore, we need to be well equipped with knowledge of what empirical therapy is required. And I won't go into the individual antibiotics, but it needs to cover Staph aureus and anaerobes in community-acquired infection, and in hospital-acquired infection needs to cover MRSA and resistant gram-negatives. So the question is, can we do better than this? This is a very poor microbiological sensitivity. And there are a few ways in which we definitely can. So this was a study done by Sarah Menzies when she was here in Oxford with us. We called it the BACTEC study, named simply after the sort of blood culture bottle system that we used. And in this, she did a prospective cohort study looking at patients with pleural infection and with heart failure, inoculating very small volumes of pleural fluid, 1, 2, and 10 mils into the BACTEC system and into the normal plain tube culture system to see if we could improve bacterial diagnostic yield. And indeed, she showed that we could by about 15% or so. So on this table, you can see in black is the extra cases that were diagnosed by dint of using the BACTEC system. It should be pointed out that you must send both the BACTEC system and the plain tube, because within the BACTEC system, there is a degree of suppression by certain microorganisms. And it would appear that the most increase in diagnosis was the other streptococci group. So the non-pneumoniae, the non-Milleri group that we seem to diagnose better. So this has become routine care, and indeed will be part of the 2022 guidelines when we publish that later this year via the BTS. So can we do even better? Molecular diagnosis is well known to all of us, especially in the diagnosis of TB, for example, using the 16S genome, which is something that's not present in humans, but is in bacteria. Can we use PCR techniques to multiply that up and therefore increase our diagnostic yield? Well, it sounds very attractive. There have been several papers that have tried to do this, but these were not linked to any clinical outcome. And so the problem is we don't know whether this was oversensitive. And of course, at the minute, it is expensive and not widely available. Having said that, these technologies are becoming bedside and becoming much more affordable. So maybe we can do a bit more. And again, I'll describe a paper just published from my group. So this was Nick Kanellakis, who's the postdoc in my translational lab. He published this paper in Lancet Microbiome earlier this year called the Torpids Study. And let me just spend 2 minutes explaining the study. We took 243 samples from the pilot study. This was a prospective observational cohort study in pleural infection. And we conducted metagenomics, meaning deep sequencing of all of the samples, and associated it with clinical outcome over 12 months. And let me just present the headline findings. So the first, a somewhat surprising finding, is the majority of patients with pleural infection have polymicrobial disease, even when looked at a molecular level. So on the table here, you can see on the right-hand side is the number of patients who had monomicrobial disease, meaning there was a single dominant pathogen. And this was 51 out of 240 patients, i.e. about 20%. And these were largely streptococcus. So if you get streptococcus, it's probably the single infectious agent, whereas the majority, 75% of patients, had a bacterial zoo within their pleural fluid. And we think this is therefore a polymicrobial disease. When we looked at the molecular analysis, it would appear that, in fact, anaerobes are the most common finding in both community and hospital-acquired disease, followed up by the streptococci and the gram-negatives. Again, that's a slight shift from conventional microbiology and may well inform our empiric antibiotic choices. And most excitingly, we have now associated the initial molecular bacteriology with survival. So just to give you the highlights, if you have anaerobes at baseline or the anginosis group at baseline, your survival appears to be really quite good, about a 90% survival at 1 year. Whereas if you have Staphylococcus aureus at baseline, your survival is very poor indeed. Now, what's the mechanism of this? It's unclear. Is it because the host response is poor? Is it host bacterial interaction? Is it because hosts with poor immune systems tend to get more aggressive bacteria? We don't understand this, but we need to understand it, and there are future studies planned to do so. So we can conclude from this study that it's a polymicrobial disease. If you get strep pneumoniae, it's probably the single infectious agent, and we have associated molecular microbiology with outcome now. And that means that you must cover anaerobes and Staph aureus unless you have strep pneumoniae on your conventional cultures, in which case straightforward benzyl penicillin or amoxicillin is probably sufficient. Now, let me ask a question. Are we looking in the correct place? So this is a pleural biopsy. All of you would have instantly recognized that this is TB pleuritis. So here we've got caseation and granuloma formation around. I said I wasn't going to talk about TB, but I am just for 1 second. If we ask the tubercle, where does the tubercle like to live in the thorax? It likes to live in the parietal pleural lining. So we know that pleural biopsies have a good microbiological yield, whereas pleural fluid has a very poor microbiological yield for the diagnosis of TB of the pleura. However, when you and I as physicians aspirate fluid, we send fluid and not the parietal pleural lining. So maybe we're doing ourselves a disservice. Maybe conventional bacteria live in the parietal pleural lining. And we started to assess this in this study. This was the audio study published by my colleague, Yanis Salidas. So in brief, what he did was he took patients who had suspected pleural infection, as you can see here, septated fluid, consolidated lung. And then we anesthetized the pleura. And before inserting the chest tube for treatment, we conducted a cutting needle biopsy, as you can see here, obtaining a tangential biopsy of the parietal pleural lining, and then submitted the biopsy with the fluid to see which had a higher diagnostic yield. And this is what we found. So in these patients, it was only a 20-patient study. 10% were blood culture positive. Pleural fluid was only positive in 20%, but this more than doubled using a pleural biopsy in the same patient. So we're looking at a much higher diagnostic yield with typical microbiology. So I think we've learned that bacteria quite like to live in the parietal pleural lining rather than in the pleural fluid. And here's an histology slide which demonstrates that. So on the left here is fluid, over here is a fibrin lining on top of the parietal pleura. These pink cells are, of course, the neutrophils, big neutrophil infiltrate, and these nests of streptococci that seem very happy living within the parietal pleural lining. The mechanisms for this, again, not particularly clear.
Last 5 minutes, please.
Thank you very much indeed. Yeah. Okay, so I'll just skip through risk stratification. Then it would be very beneficial for us to understand which patients are going to have a poor outcome in pleural infection. I'm going to skip through this in the interest of time. We have done a large study retrospectively that has identified this criteria. This is the rapid criteria. You can read through those yourselves, but in brief, higher urea, higher age, non-purulence of fluid, hospital-acquired infection or a lower albumin are associated with a poorer clinical outcome. In retrospective analysis, this looked to be a very powerful predictor of poor outcome. So this was discovery, this was retrospective validation. We have since prospectively validated in this study. This was the pilot study, which was done by John Corcoran, and in it he demonstrated that survival was very associated with rapid score all the way out to 1 year. So this appears to be a very robust prediction tool for assessing who's going to die of pleural infection. It also predicts some other things. It seems to predict lung function at 3 months, and it seems to predict who gets surgery in the wrong way. So patients who have the lowest risk appear to have the highest surgical rate, whereas patients with the higher risk have the lowest surgical rate. I'm sure we'll debate that in the questions. Finally, then, in my last section, what about intrapleural treatment? We know that this is a septated disease, and you can see that being septated both on ultrasound and on thoracoscopy, and moving these septations seems to be an important thing for us to do. MIST-1, very famous study now, streptokinase versus placebo. Unfortunately, this showed that there was no benefit of streptokinase whatsoever in a 450 patient study. And for a number of reasons, including viscosity of the pleural fluid and also the biofilm, we went on and conducted the MIST-2 study, which I'll talk about just for the last couple of minutes. In it, we used a combination of DNase and TPA, double-blind placebo-controlled study. It had a radiological outcome looking at the percentage hemithorax occupied by pleural fluid day 1 to day 7. And in it, we demonstrated that with placebo, you shift about 30% of the pleural fluid. Same with TPA, again, no better than placebo and DNase, but the combination doubles drainage, and it seems to clear most of our patients completely. Not only that, but it's associated with a reduction in surgical rate of 83% and a vast reduction in time in hospital. So how do we use it now? Well, in my practice, I use it where there are no other treatment options available. I still think if a patient is doing badly, they should have surgical intervention. The question of whether it's preferable to surgical management is a different question. Now, we have got a lot of experience in this disease now. This was a PubMed search recently, 450 cases of TPA and DNase reported. And then this study again by Ehab Badawi, nearly 2,000 cases of TPA and DNAs over 8 years. And we've demonstrated a low bleeding risk and the factors associated with bleeding, which I'll just skip by for a second. Irrigation is another option for you. So this is large volume saline flushes, 250 mils 3 times a day. This one non-blinded randomized study appeared to demonstrate a significant reduction in surgery, but it was an unblinded study. So we use it if patients don't have access to TPA and DNAs. Now, let me just finally finish talking about surgery, aware that we have a surgical expert on the call as well. Who should we operate on, when, and do we operate on all patients up front? I think that's unclear. There are 2 randomized studies in the surgical literature that suggest that this is the case, but they are both methodologically flawed. So one was extremely small, and the other had no blinding criteria, a selected population, and no objective decision-making criteria. So unfortunately, although they're positive studies, I don't think that that is reasonable to say that we should operate on everybody up front. And 70% of your patients will recover with your management rather than surgical management. So we haven't made the case for immediate surgery. Where do we go next? My last couple of slides. Well, TPA DNAs appears to work. Its role in all patients at the front door is unclear. VAT surgery is much better than thoracotomy. Its early role is unclear. And we've therefore just completed this study, the MIS3 study, in which we have randomized patients to early VATs, DNA TPA, and standard care. And we should have results of this in publication in about 6 months' time. I won't go into my conclusions. I've been through them very quickly. It's been my absolute pleasure talking to you today, and I must acknowledge all of my colleagues who contributed to all of these studies. Thank you very much for your kind attention.
Jazakallah, Naj. Excellent talk as always. I'll just see the chat box. I think there's just a comment from Dr. Salman Ayaz, MIS2 study with TPA DNA effectiveness. I think you've covered that already. Mm-hmm. I don't have any other questions at the moment, so I can start off. I have a few questions. So Naj, what do you think is the optimal timing for surgery in patients who've got complicated pleural infection or empyema if the patient is a surgical candidate? And would you consider fibrinolytic therapy if the patient is a surgical candidate, for example, if there is a delay in surgery?
You've asked the key questions there, the 2 key questions to which, of course, I don't have a clear answer, but I'll give you my opinion if that's okay. Optimal timing. I think the optimal timing of surgery is earlier than previously we thought. We do have data from our thoracic surgical colleagues that delay in referral results in a higher thoracotomy conversion from VATs, and that makes some sense. So the old BTS guidelines suggested wait 7 days. We've pulled that back to 48 hours. Now, why have we said 48 hours? Because a lot of patients will recover in that first 48-hour period. And therefore, doing it at day 1, you're going to over-operate on people you don't need to operate on. So 48 hours if they're not thriving. And to be clear, Badar, behind your question is, how do we know they're not thriving? It must be a combination of pleural shadowing on radiology and a sepsis syndrome. So if they've got a bit of pleural thickening, this is not an indication to operate. And the CRP is coming down, they will get better on their own. Now, to your question about should we give fibrolytics first, we don't really know the answer to that. I have done this several times because we've referred a patient on a Friday, our surgeons will operate on Monday, and we've given it over the weekend, and that's worked very well indeed. In fact, quite a few of those patients then don't need to have surgery at all, which is rather good. And even when they've operated, there hasn't been a big issue with bleeding. So I'm very comfortable doing that. I would, however, say that at the minute, the optimal management of someone failing medical therapy is still surgery, if it can be done VATS and if they're fit enough.
Excellent.
Thank you, Doctor. Thank you, Dr. Najib. Very nice presentation. There's a question from Dr. Jawad from Saudi Arabia. He wants to ask, is there any clear indication or recommendation for tube thoracostomy in advanced transudative pleural effusions?
Okay, thank you. So, thank you, Dr. Jawad. So by that, I take it you mean hepatic hydrothorax or cardiac failure and so on. Yes, the indication for it is symptoms, but one needs to be very careful with the treatment intent before one puts a tube into a patient like this. So the danger that I think Dr. Jawad is giving us reference to is a patient is referred by hepatology colleagues, they've got hepatic hydrothorax, please put in a chest tube. Yes, no problem. We as technicians put a chest tube in. The problem is that this patient, we already know, will have 2 or 3 liters output per day. And the nightmare for us as pleural physicians is coming back a week later and they've dumped all of their albumin out of their chest tube, and they've got low blood pressure and so on. So one needs to be clear why we are treating the patient. It is not to dry the pleural space, it's for symptomatic benefit. My option in that situation is to do a large volume pleural aspiration, not leave any plastic in the chest, optimize management of the underlying organ dysfunction, and then if necessary, we can talk later about an indwelling catheter or talc pleurodesis if they need repeated aspiration. I hope that's answered the question, Saadia.
Dr. Mahmood, Ayaz wants to ask a question. Yeah, Dr. Mahmood.
I wanted to know that what amount of pleural fluid in one hemathorax would you recommend that this is the critical level where you would require a drainage?
That's a brilliant question. Thank you so much. I think that's a complex question because our ability of detecting pleural fluids to low volumes has increased with the use of CT and ultrasound. So on an X-ray, one would say, well, if there's more than about 1 or 2 rib spaces, it would be fine. I think the problem with pleural infection is it is unlike malignant pleural effusion where we treat symptoms. It is the source of the infection, is it not? So I would recommend anything greater than 2 centimeters on an ultrasound, and I'll just explain why. Richard Light many years ago did a very simple study where they did ultrasound on all patients with pleural infection, and they measured the amount of fluid and then documented what happened to the patient. And the majority of patients with less than 2 centimeters of parapneumonic effusion resolved just with antibiotics. So it's probable that even if it's frankly infected, it will resolve itself. The great difficulty, as you will know as a thoracic surgeon, is that it isn't a simple effusion. So it's pasted in different areas. And as soon as we start to see loculation septation, I think these should be drained by myself.
Thank you. Thank you.
Okay. There's a comment from Dr. Hafiz Rahman. He works in ITU, working in their DGH. So we struggle to get surgeons to accept a referral. Hope with this fresh information, I can challenge them in the future. So
yeah, just don't use my name, but that's fine.
I don't see any other question. I've got a couple of other questions, yes. Naj. That's okay. Would you ever consider medical thoracoscopy in managing pleural infection?
Yeah.
And the second one, which I have, in the rapid score which you've published, non-purulent fluid gives you a score. What do you think is the basis for that rather than the purulent fluid?
Yeah, okay. So I'll answer the second question first, if I may. So it was a great surprise to us that non-purulence was associated with a worse outcome. Sorry, I was taught in medical school that purulence was bad and empyema worse than complicated. But we now have 3 very large data sets that confirm that this is absolutely true. So it is true. What could the mechanisms be? There are at least 2 mechanisms that are plausible. One is purulent pleural fluid tends to septate less. And I don't know why that is, but if you've got non-purulent fluid, we tend to see more septation. In purulent fluid, it septates less. And therefore, you could argue that with an adequate sized chest tube, you'll drain all the fluid out. That's one option. The second option is more of a biological mechanism, which is if a patient is not able to create pus, which is dead neutrophils and dead bacteria, then potentially they have some immune deficit within their pleural response. And I think that's a very attractive option, and that's probably the reason. Now, let me go back to your first question, which is medical thoracoscopy. I like doing medical thoracoscopy, but I enjoy doing it. And, you know, it's a great fun thing to do, and it's really interesting to teach and so on. I think there's a problem with medical thoracoscopy, which is if you think about the stages of pleural infection, if we've got to the stage where there is a cortex over the lung, then no medical thoracoscopist has the skill to strip the lung cortex, and that needs a surgeon. So that's easy. And then we are therefore confined to earlier stage pleural infection. And then, yes, it would be possible to insert a trocar, use forceps to get rid of the septations and put a tube in. I've got no objection to doing that, except we have randomized controlled trial data that TPA DNase works really well. So I think MIS2 has got rid of the need for early medical thoracoscopy. There are some groups who have compared medical thoracoscopy to MIS2 in a randomized trial, very small randomized trial, seeming to show that medical thoracoscopy gets you out of hospital quicker. And I can believe that because medical thoracoscopy occurs over 1 hour, whereas the MIS2 drugs are given over 3 days. So maybe there's a study to do there. At the moment, as Beenish will attest to, if there's pleural infection, we avoid doing medical thoracoscopy. We use MIS2 or we talk to our surgeons.
Excellent. Thank you very much. I think we're about time. So excellent talk. Excellent as always. Thank you very much.
And I've just seen a comment in the chat box. I'll answer other questions in the chat box as well. Very happy to do that during the afternoon. Thank you so much.
Thank you very much.
Barakallah fi. Barakallah.
So I'll hand over to Professor Saadia Ashraf for the next session.
Okay, thank you. Thanks a lot. A very nice talk. And our next speaker is Dr. Beenish Iqbal. She's a clinical research fellow at Oxford Research Trials Unit. Our talk is Mending the Holes, Managing Pneumothorax in 2022. Over to Dr. Beenish Iqbal.
Thank you very much for having me here. Can you see the presentation, right?
Yeah, we can.
Yeah.
Okay. All right. So as you very kindly introduced, thank you very much for the introduction. I'm going to talk about managing pneumothorax in 2022. And this talk is going to be just covering what we know now, what we didn't know about 10 years or so ago when we had the very famous BTS cruel disease guidelines for pneumothorax in 2010, and then taking on from there. So this is the brief outline of what I'm going to talk about today, is overview of classification and why we need to treat pneumothorax. Then I'll touch upon the current management of pneumothorax, as well as some recent trials that have helped guide our management in 2022, and then some future directions. So just getting the nomenclature right from the beginning, I'm not going to delve too much into detail, but just to give you like a very quick summary of what when we talk about pneumothorax and what we mean with spontaneous and non-spontaneous. And I'm going to talk mainly today about spontaneous pneumothorax, primary as well as secondary. And by primary, we mean that no underlying lung disease. And with secondary, we mean elderly population and underlying lung disease. So obviously, the boundaries are not always very clear, and there's a lot of overlap about which I'll talk later. So as I understand, majority of us have seen this X-ray in our clinical practice, which shows a moderate size right-sided pneumothorax. And the moment as a resident or as a physician, we look at the X-ray, we're like, okay, it probably needs doing something, or probably needs doing nothing, as my colleague puts it. But then we look at the patient and we say, okay, is it like the textbook tall, thin, lean man pacing around in the department looking at their phone? Looks very well. Do I really need to do something about it or not? And we label it likely primary spontaneous pneumothorax. But when we look at the patient who is an elderly gentleman with more than 100 pack-year history of smoking and gasping for breath, then definitely we think, okay, there's an underlying lung disease, and we label it as secondary spontaneous pneumothorax. And definitely the shift of anxiety of the physician changes when they look at these two different cohort of patients presenting with the same X-ray. So why we need to treat pneumothorax? I've just populated some data from UK studies, and as you can see, 14.1 admissions per 100,000 population was looked into by my colleague Rob Halifax in 2018, and I think it summarizes as well that majority of the patients who require inpatient admission have underlying secondary spontaneous pneumothorax, and for the primary population, we know they are usually on the fitter end of the cohort, and we tend to treat them with more conservative management now. But interestingly, for the case of this presentation, I looked through some data from Pakistan, and I could see a very good retrospective cohort study done in '99 by Al Khan University, Karachi, and another one done 10 years later. And what they summarize and what interested me in that is the underlying etiology of pneumothorax that happens in the population that gets admitted. And you can see the pulmonary TB kind of tops the list, both in terms of the cases for primary spontaneous pneumothorax as well as other causes of which COPD, which we see in our part of the world much more being the likely cause of secondary spontaneous pneumothorax. And you can also see that the resolution time of this is much longer in the pulmonary TB group compared to PSP and COPD, which obviously tells that living in an endemic country with TB, you're bound to get much worse disease. And then similarly in the study, they also gave us a bit of a breakdown of the causes of the secondary spontaneous pneumothorax, and you can see again TB tops the list. So that makes me think and have an inference that age-based cutoffs kind of blur in TB endemic countries. And that is in itself a thing to think about, that when we're talking about the younger population and the older population having this and that, does it really matter in a TB endemic country? Because you don't know if you think it's a young, tall, thin, lean man who might be having underlying pulmonary TB causing the disease. And that would completely change the picture based on the data we have. So this is the, as I mentioned, famous BTS pneumothorax guidelines from 2010. And they have for more than a decade guided physicians about the management of pneumothorax. And I think they have been very successful so far. But the problems I have with this is based on quite a few attributes of what is the size of pneumothorax on the X-ray, what are the types, primary versus secondary, age cutoff, smoking, and other concern of underlying lung disease. And as I will elaborate a little later, that how we have moved forward from that. So looking at the primary end of the perspective, we see, okay, do we have a pneumothorax? It looks a little bit bigger, we measure it. And I remember being a resident back in Pakistan, I used to know this algorithm by heart and have to measure that pneumothorax on an X-ray film and then seeing what I need to do. But then you can see probably in the algorithm that we tend to not jump in with the chest drain in the first, as a first management. We try some lesser invasive options first, like an aspiration before going on for a chest drain. But there is a small box there, which has now become much more relevant now about conservative management of large, minimally symptomatic pneumothoraces, and I will delve into that a little bit later. And this end of this, the algorithm, which is a secondary pneumothorax, underlying lung disease, you see these patients are much more breathless and symptomatic, even with smaller pneumothoraces, because the lungs cannot handle the pressure that develop with the small air leaks. And then we tend to be a little bit more aggressive with them, with trying to intervene more than less. But then what has changed in the management of pneumothorax if that algorithm has been kind of helping us and we have been doing what we are doing? I won't go into too much detail about the sizes of the chest drains. I think it's very difficult, especially in Pakistan being a resource limited country. I never use a Seldinger chest drain in Pakistan, but I know now they are a bit more rapid chest drain kits, probably pigtails that they're using. So it could be simple aspiration with a green needle, or it could be a chest drain, but more often we ended up putting larger bores surgical drains by thoracic surgery because of either TB related diseases or causing pneumothoraces or COPD. I think if I say in one line, what has changed in pneumothorax, I think less is more now compared to what we used to do before. And I would say probably at least for PSP. And this is not just what I think should be done. It's based on quite robust randomized controlled trials. And it's an absolute pleasure to work with Professor Rahman, who has contributed significantly with these trials to our knowledge and how we should be managing pneumothorax in this year. So this is the draft BTS pleural disease guidelines, which Professor Rahman and his colleagues have very, I would say, nicely put together. And it's still out for public review and not published yet. But sorry for a busy algorithm, but what I would try to point out is the question that we are asking is the patient symptomatic? And I think that's a big jump in how we manage now the diseases, specifically pneumothorax, but other as well. So the patient is at the center of the management and not what a physician thinks looking at the size of the drain of the pneumothorax, or whether it's a primary or secondary. Is the patient symptomatic, or are they in the high risk categories? And this is the approach, I think, which has been shaped by all of these brilliant trials that have been done by colleagues. And I'll come to that later and probably would give you a quick overview of the recent important trials that have led to the formation of these new guidelines. And importantly, a big trial from Gary Lee Group in Australia came out in 2020 with the conservative management of PSP. And by that, it meant that they did one-to-one randomization of about 316 patients across 39 centers, in which they randomized moderate to large pneumothoraces primary spontaneous pneumothorax to conservative management, i.e. no intervention versus an intervention, which is a chest drain with an underwater seal and admission. And the primary endpoint was a chest X-ray resolution of pneumothorax in 8 weeks. And unsurprisingly, you can see that in the patient in the intervention arm, which got the chest drain and got treated, there was a 98.5% improvement. But going for the some statistical corrections, the conservative arm didn't do that bad either. And you can say that more or less they have been, I wouldn't say what the views were equal, but I would say non-inferior, which was the design of the study. And there were fewer adverse event recurrence in the group. However, it has to be taken a little bit with a pinch of salt, that you can see that this is the participant group. And in the intervention and conservative arm, you can see that they were like minimally symptomatic patients that they have selected. And also they screened more than about 2,000 patients and just managed to get 316 for the randomization. So whether they were very carefully cherry-picked patients who were minimally symptomatic, which we knew from BTS 2010 guidelines that they can be managed conservatively. So I think it's a brilliant piece of work, but equally, and it helps advance our knowledge toward conservative management, but then again has its own drawbacks and caveats. The next is the ambulatory management of primary spontaneous pneumothorax, a brilliant piece of work done by Rob Halifax and Professor Rahman group. And this was to look at, okay, these are the patients, we think they have primary spontaneous pneumothorax, and a physician has decided to put chest drain in or an intervention. And we have tried to randomize them to a ambulatory management with a pleural vent, and I'll show you the picture later, which is a device that you just put in the second intercostal space, and they can go home with it. It has a one-way valve to release air into the environment, and the other one is the standard intercostal chest drain in admission patients. And what they did is, again, as a randomized control trial, about 236 patients from 13 centers, and the primary endpoint was admissions to hospital in 30 days, and that was including readmissions in the ambulatory group. And what they found is a significantly reduced hospital stay in patients in the ambulatory arm, but they also noticed 12% serious adverse event in the ambulatory group. Well, I think I would also think about this in a way, which also has Rob has and the authors have mentioned in the discussion, that when a patient is in hospital, they have an indefinite access to a doctor, and every time a doctor comes to see them, he or she doesn't mark it down as an adverse event. It's just a part of the standard care. When a patient is in ambulatory, is not in hospital, and they're calling you, coming to hospital, that can be over documented as an adverse event. Nevertheless, there was no increased mortality in either group. And this is the pleural vent device that was used for the case before this study, and now has been increasingly used in the UK, and we are also in a process of getting it finalized for our own hospital. And just to mention that there was no difference in the pain and the VAS pain and breathlessness score between the two arms. So that gives us a more confidence that the patients who are younger people who have other students or daily wages, for example, in country like Pakistan, they cannot afford to stay in hospital, or they shouldn't need to be in hospital because there's a risk of carrying other infection, and also with an ever-increasing demand of beds, can we ambulate these patients and compared to keeping them in hospital with a bubbling chest drain, which might resolve within 1 or 2 days. And next comes this ambulatory management of secondary spontaneous pneumothorax, and this was done by Steve Walker from the and Nick Maskell from Bristol group. And this study looked into whether we can extrapolate the same stuff that we found in primary pneumothorax of ambulatory management. Can it be extrapolated to secondary spontaneous pneumothorax? It was again a randomized control trial. They couldn't recruit as much as they expected to recruit in first place, but I think I would still like to congratulate them for enrolling for 41 patients, because we know these are older, sicker cohort with lots of other comorbidities that might be keeping them in hospital, and trying to randomize them to ambulatory and conservative arm is quite commendable. And their primary endpoint was chest X-ray resolution, admission hospital in about up to 30 days. And again, they were randomized to an ambulatory arm in which initially they went for the pleural vent, the same one as Rob went for the ramp trial, but then they noticed that there were more adverse events in that group. So that was replaced by chest drain with an ambulatory device attached to it. And those patients who were stable enough could go home. And the other ones were the ones that had a chest drain and got admitted to hospital with an underwater sea. And they didn't find any difference in the length of stay because the ambulatory arm patients had more adverse events, more readmissions and to hospital. And they had 56% adverse rates in the ambulatory arm. And this is what they have been using in the pneumostat device, which we call, made by the Atrium company. And I just showing it for knowledge of the audience, that you can attach this to end of a chest tube. It has a small container that can contain some fluid, and it is a one-way valve that allows the air to escape and not to cause that you can't aspirate the air again. And that has been successful in the primary spontaneous pneumothoraces as well, and that has been used in patients in our setup, and Naj can second that for the patients who have secondary spontaneous pneumothoraces that have prolonged air leak, that are stable, can go home, but just staying in hospital because they're attached to a chest drain bottle and an underwater seal. So these are the patients, carefully selected group of patients with very close follow-up. They can be discharged into community with that attached after proper advice. And lastly, I would just quickly touch upon a surgical trial done in 2018 for the surgical treatment versus conventional chest tube drainage in primary spontaneous pneumothorax. It was a trial done by the Danish group, and it was a randomized controlled trial, and they managed to recruit 181 patients with a primary endpoint of recurrence of ipsilateral pneumothorax post-VATS or post-conventional chest tube. And I would like to say I'm not a very big fan of this trial because it seems like a lot of recruitment bias, and they have mentioned that they had to close the trial or stop recruitment because of ethical reasons. Not really delved into that in detail what they were, but what I can sense is that because the patient presenting to cardiothoracic centers, and I think when a patient is in a surgical ward in a cardiothoracic center, the intention is always to treat more than less. And there was no conventional no conservative arm group in that case. And they obviously showed superiority in VATS, causing lesser recurrence in the ipsilateral pneumothorax compared to chest drain. But now that we know more that these patients can be managed with conservative management with no surgical or without any intervention if it's not needed, I think that has to be taken into consideration whether a very intervention heavy trial would guide our management. Nevertheless, the patients who have a bubbling chest drain for many days down the line, their fit population, we all involve our surgical colleagues into that, just so that to surgically treat the pneumothorax. And also after a single episode in high risk population with regards to the occupation, like pilots and scuba divers, never came across one up to now, but the ones that would like to have a definitive treatment for their pneumothorax toward recurrence, we all refer them to surgical colleagues. So coming back to the draft BTS pneumothorax guideline algorithm, I think as I just mentioned before, this is a paradigm shift, I would say, with regards to the question we are asking and how we're answering it. And you can probably see that instead of the dichotomy of primary and secondary, we now have the 4 treatment options that we think patients can opt for. And the very interesting question and very intelligent question, I would say, is what's the patient's main priority? And you can see that these are the questions that we are asking at 2 steps. So the first step we are asking, is the patient symptomatic? Does the patient really need doing anything? So just us picking up a pneumothorax in the X-ray shouldn't excite us to put a tube in or do an aspirate. Does the patient really need it? And the second thing is, what's the priority of the patient? And we shouldn't be judgmental on that, because patients have their own life, and no one really wants to stay in hospital if they don't need to attach to a tube, which is obviously painful. It comes with all of its problems, as we all know in our clinical practice. So I think with regards to that, now we know what we know, and we have, and as I said, Professor Rahman and colleagues have very nicely summarized that in the guidelines that are coming. What are the upcoming trials in pneumothorax? And I'm absolutely delighted to be Professor Rahman's research fellow, trial coordinating for RASPER trial, which is a randomized controlled trial. We're going to start recruiting soon for that, with suction and no suction question in primary spontaneous pneumothorax, which you all know that if we have a bubbling chest drain, it's been bubbling for 1 or 2 days, should we put it on suction, and when and why, and does it really work? And the other one is concept trial, which is looking at the conservative versus interventional management for symptomatic patient with PSP. It is a kind of a extension, I would say, of the PSP trial done by Gary Lee's group. But as I mentioned earlier, they were very minimally symptomatic cohort, which have been conservatively managed anyway. And we're going to ask this question in the symptomatic group, that do they really need to have an intervention, or can they be managed conservatively? And lastly,
last 5 minutes, please. Thank you.
Yeah, okay. To my limited knowledge, another commit ED trial is looking into conservative versus intervention management of traumatic pneumothoraces, which I think is again a brilliant idea, because again, these are the pneumothoraces, say trauma pneumothorax need drainage, but now they're looking at, can we manage these ones with conservative management as well? So in summary, I think how we manage pneumothorax in 2022 is the patient-centered management. Now we have more options, but I would say for a country like Pakistan, in which if we don't have very fancy drains and all that, I would say keep it simple. If they need a chest drain, okay, we put a chest drain in, but I think there should be more appetite into looking at some locally manufactured ambulatory devices, just trying to ambulate these patients quicker, and exploring conservative and ambulatory options, which is now the main trend of how we manage patients in our pneumothorax cohort, being minimally invasive as where we can. And lastly, something that's very dear and close to me is more work needs to be done in less widely studied pneumothoraces as well, now that we have done some brilliant piece of work on primary and secondary spontaneous pneumothorax, or another large and very less widely studied group of iatrogenic pneumothoraces. And that's where I end my talk. Happy to take any questions.
Beenish, excellent talk. I've been told that Professor Saadia Ashraf is having some technical issues, so I'll take the questions. So well done, Beenish, and well done on leading the trial on suction, which is obviously an unanswered question at the moment. So I've got a few questions. So role of oxygen therapy in conservative management of primary spontaneous pneumothorax and pleurodesis in primary spontaneous pneumothorax.
So obviously I have Nigel on talk, so I will divert most of these difficult questions to him. But in my practice, I think the study that was done many years ago about giving high oxygen to patients to help with pneumothorax, this is not the practice we do, and we haven't seen specifically that if the patient doesn't need oxygen, you putting in oxygen is going to help with that. So that's why we can safely ambulate these patients. And we haven't seen that if we're not giving them oxygen and not admitting them to hospital, they do any badly, and there's no decent data to suggest that we should be over-oxygenating these people. And secondly, with regards to the pleurodesis, as I said, we're not doing it as putting a chest drain in and the drain is bubbling and we put some talc just to see if it works. We're doing it, I think the surgeons, that's where we revert the cases to. And if the surgeons, as part of the definitive management, they are doing VATS, pleurectomy and pleurodesis, but not us physicians on the wards. Naj, do you want to add anything?
Thanks, Beenish. No, I mean, you've answered beautifully. The one thing I would say is the oxygen thing gets very poorly understood, doesn't it? And if we just think about the physiology, the point of oxygen increasing resorption of a pneumothorax is that we are displacing nitrogen from the tissues and allowing the 70% nitrogen within the pneumothorax to then transfer off into the blood supply. So what that means is that you've got to give the patient as close to 100% oxygen as you can, and it increases resorption from 4% a day to 7% a day. It's a very small treatment effect. if you think about it, when I was training, I was told if the patient can't have an intervention because they're too sick, give them oxygen. Well, all these patients will be in ventilatory failure and you'll drive them into needing NIV. So I think in the round, high dose oxygen is just not a very good option.
Thanks.
Okay.
Yeah.
Okay, thanks a lot. There's another question that is bubbling drain with suspicion of bronchopleural fistula. Would you consider suction while awaiting surgery, and how much difference it's going to make?
I think it's a very beautiful question, and that's kind of the question we're trying to answer, not, I would say, directly in the RASPER trial, but I would say certainly in our practice, I don't think anyone knows the answer to that. And if you think that there's a bronchopleural fistula, by which we mean like prolonged air leak, in a primary spontaneous pneumothorax patient, I think most of our colleagues would say do something more than putting a chest drain in. And sometimes that something could be putting the patient on a suction. No one really knows what level of suction would do good for the patients. I think there are also made up levels for that. Or some would say, all right, if there's some worsening subacute emphysema, let's put in a bigger drain. But I think we have very excellent communication with our surgical colleagues. And if we think a primary spontaneous patient is leading that way, we tend to involve surgeons sooner. But I think it becomes a very relevant question for patients who have secondary spontaneous pneumothorax and who have a bubbling chest drain. And we can see an obvious bronchopleural fistula on the CT. I think the question then arises, is the patient fit for an intervention, i.e. surgery? And if they are not, and most of the time they are not, because they are sicker people with underlying lung disease, what we have done, and in these situations, having a large bore chest drain to manage the air leak, and then if they can tolerate to go home, we have sent them home with the ambulatory device attached to the large bore chest drain, and with close monitoring, obviously. And I won't advocate people doing it when they don't have very good service to follow up these patients and have very close, or the patients who cannot come back to the hospitals. And obviously this is usually what we do. And the other things that I think people are doing is are some going for some endobronchial valves and trying to collapse the likely site of the leak, or pleurodesis. But I think these are the things that obviously I'm not very familiar with, and I can ask Najib for his comments on it. But I think what we are seeing that most of the patients just need time, and with time they usually go away, these leaks. So whether they need to spend that time in hospital or can spend it out of hospital, this is a good question when specifically they are not surgical candidates.
Okay, thank you. Very well answered. There's another question. Is there any role of pleural manometry while we are managing with the chest drain?
I think pleural manometry, I would probably say it's a dark art, and its role in regards to the pneumothorax, I'm not very clear about the question, but I think it certainly has been studied in trying in the pleural effusion and the drainage, and what difference does it make in the pressures, intrapleural pressure and symptom management. And I think this is something that is what I have read in the literature is very subjective, and different people using data very differently. And I think what I would like to say, it's an expensive thing to do, especially in a resource limited country with very limited information it can give to you. More studied in the case of pleural effusions and their impact on the symptoms of the patient. So we don't advocate using pleural manometry in pneumothoraces.
Okay, thank you. Jawad Nasir is saying there's a comment, very impressive talk by Dr. Beenish, very updated one.
Great. Anybody has any comments or question? We have a couple of minutes before we end this session.
I can ask. Beenish, is blood patch pleurodesis affected? So if the patient, let's say, is a non-surgical candidate and he's got a non-resolving secondary spontaneous pneumothorax with severe bullous emphysema, would you consider a blood patch or pleurodesis even if the drain is bubbling?
I think it's a very good question. And obviously we don't have any randomized trials to support that, but we have definitely seen in our clinical practice from small case series that it works. I think the only thing that I would say is that the patient, you have to really stand with the patient if you put a blood patch in that, because you know they have to draw blood, then you have to put it in there, you have to clamp the drain. And we have seen patients collapsing in front of us because of the air leak being so excessive that they cannot tolerate clamping the drain even for a minute or so. And I have seen a couple of patients in which it works, and I think it's worth a try. When you don't have much options, I think anything that can work for the patient, you just try your best. But now that we know that if the patient is otherwise stable, and I think it's probably a talk to sit down with the patient and give them the options that, on the limited options that we have, what can we offer them? And if they are up for it, we can say that we have some evidence, but we don't have a big trial supporting that. And then there is a risk of harm as well if they obviously have significant air leak. So I think that's a very case thing to say. And certainly it has been tried and it can be tried. But again, case selection has to be important. But obviously stand with the patient and don't give them blood patch and walk away.
Dr. Mahmood has got a question.
Thank you. Beenish, I just wanted to know your opinion regarding that. What's the best chemical you would use for doing a pleural disease?
In pneumothorax in general?
Yeah, when there's a recurrent pneumothorax.
So we do talc pleurodesis, we use the sterile talc, and I think the other ones, I'm pretty sure Naj can probably add bits into that. Regards to the bleomycin and tetracycline, I'm not very sure, Naj, if they have been used for pneumothorax pleurodesis.
Yeah, so all of them have been used, thanks, Beenish, and talc has the best data, the best evidence base in terms of efficacy. But frankly, all of it is reasonable. And if you don't have access to talc, then either bleomycin or in younger patients, I'd probably use doxycycline. Let's just remember, none of these are magic. All they do is injure the pleura sufficient to cause an inflammatory reaction that then causes adhesions. Our surgeons, when they're doing pneumothorax surgery, standardly, even in young patients, will do an apicectomy with their stapling device, and then they'll use talc as well. And I guess the message for our surgical colleagues is the key intervention is the pleural surgery, not the lungs. That's prevents recurrence.
But the problem in Pakistan that talc is not very frequently available to us, especially in a good quality form. So we are always looking for some other substitute, so that if possible we can do a pleural disease if it is required.
Yeah. So Dr. I mean, doxycycline absolutely fine. Bleomycin, I worry a bit because it is a chemotherapy agent, so I do worry a little bit about that. Some people have used betadine, for example, but as we go down the list, the evidence base becomes less and less. So probably doxycycline is the best option.
Yes, I think doxycycline is the best.
Yeah, thank you very much, Dr. Beenish. Thank you very much for this elaborative talk. Can I have inference about the hydropneumothoraces? Should we go for a large bore single tube, or can we use dual tubes for a better effective management? Though, I mean, not in the common practice, but still your comments, please.
I think it's a very good question. And I think what's important is what we call hydropneumothorax, and what in my head I have is whether you have put a chest drain in for a patient with malignant pleural effusion, complete whiteout, and you put a chest tube in. And then once the fluid has been drained, now that you see that there's a pneumothorax. Now the question is whether this hydropneumothorax is just a trapped lung that you're just seeing on the X-ray, with some the lung is failing to expand because the visceral pleura is so thickened with the malignancy that is not expanding. I think in that case, what we do, I can tell you our practice is that if we attach the chest tube to an underwater seat, if it's not bubbling, or to digital suction, if there's no air leak, and we just tend to, after we have drained the effusion, we tend to clamp the drain. And if and repeat an X-ray a few hours later, and if it remains stable, the patient remains stable, I think we can safely say that this is just a trapped lung, which wasn't evident when we put the chest tube in. But obviously, when sometime you can develop drain-dependent air leaks, in which there would be a hydropneumothorax with the fluid as well as some air leak, And I think in that case, you obviously have to treat, which is a bigger problem for the patient, whether it's the fluid or it's the air leak. And that can happen when you're trying to drain an effusion and trying to drain a lung that doesn't want to open up. And by just you putting a chest tube in has caused some visceral pleural defect that is causing air leak. And now the management has to be based on that. I think the question with regards to putting a bigger drain would be guided by what the bigger drain is going to do. If you think that the drain you have put in, the patient is having an ongoing air leak and is managing okay with it, there's no worsening subcutaneous emphysema, there's no worsening pneumothorax on the x-ray, I won't necessarily put a bigger tube in, because we know that the drain we have is sorting the problem out. I think the only problem will arise if you want to send the patient home with a drain, and we know that the smaller bore drains, they tend to kink and with an air leak, and in that case you can make an argument of putting a bigger tube in. And recently Najib can elaborate on that as well, that the patients who have ongoing air leak with malignant pleural effusions, and we think it's a drain dependent leak rather than a pneumothorax in itself, we tend to put IPCs for these patients and attach them to one-way valves, and that is something that can be done to solve the problems of fluid as well as air. IPC, I mean indwelling pleural catheters.
No, I agree, Beenish. I mean, I think this is, so to your point, Dr. Ayaz, as soon as you see hydropneumothorax, it's the differential that matters and working out the differential. Is it a trapped lung? Is there a true bronchopleural, or is it this middle ground, which is drain-dependent air leak? And then depending on which way, what the physiology is doing, your response will be different. In my experience, just to add to what Beenish has said, the vast majority of these are just trapped lung, and they don't really need anything major doing other than a solid diagnosis of trapped lung. And that, of course, is a clinical physiological diagnosis. So drain the fluid, they get negative pressure, pleural space, symptoms, and then you're solid that this is a trapped lung. And the key thing is not to put suction on those patients, because then you will create a bronchopleural fistula. Whereas if they've got a true BP fistula, here the digital devices are really good, because they will tell us exactly what the amount of air leak is, and then we diagnose that. I think the DDL, the drain-dependent leaks, are the hardest ones to diagnose, and it just takes a few days just to work it through and then to do clamping trials and so on. So, I mean, I agree with, as always, I agree with Beenish.
Thanks a lot. It's a very enlightening discussion. We can go on for long, but unfortunately we are already out of time. So there's a break, and we'll have a short break, and we'll come back at 5:30.
So we'll be taking a 5-7 minutes comfort break and starting next session. So you can stay log in if you like, but and then we will request all the next chairs and speaker, you know, they can come on the main gallery. Thank you very much. Thank you very much, everybody. And I will let, hold on, Doctor. Maybe, yeah, you can.
I think there are some questions in the chat box. If Beenish.
Sorry, I can't hear Dr. Ganaie, what you said.
Sorry, Beenish, I said there are some questions in the chat box. If you can answer the questions afterwards.
Yeah, sure.
Thank you.
Thank you.
Thank you.
And Badar and Professor Khan, do you mind if I come back for the second session for just my learning? I'd love to attend.
Yeah,
sure. Why not?
More than welcome. Thank you. We'll be back in 5 minutes. Thank you. Just checking is everybody is coming on board. I believe Dr. Talha Mahmood is here as well. I have make you co-host, and Dr. Salman Ayaz is here already as well.
Right, so let's see if I can get this sharing to work.
Yeah, we can check that.
Can you see it at all?
We can't. Let me see. So it should be able to work for you.
I've started screen sharing.
Okay. I make you co-host now, so you can try again. And Dr. Talha Mahmood, you are also, I'm going to make you co-host, so you should be able to mute and unmute yourself. Now try again to share.
See if this will work. See if this is an issue.
Yeah, hello. Can you hear me now?
Yes, Dr. Talha, we can hear you, yes.
Yes, you can hear me now.
Yeah, we can hear you.
Yeah, this is Dr. Talha Mahmood. So
Yes.
I am now available.
Perfect.
We are about to start.
Thank you. We have 1 minute. We'll just checking some slide checks. So that's great.
I don't know why this will not let me share.
Yeah, all the settings are okay. Yeah, so
My settings look okay. And just trying to see why it will not.
yeah.
Let me just see. Okay, let's see what it'll do now.
Should we start?
Okay, just a moment. Let me see that I may have to quit and reopen. Give me one.
Yeah, that's when you can double check it. Yeah. Okay, I'll let you start the proceeding. Okay.
Assalamu alaikum warahmatullah, and good afternoon, everybody joining us today from Pakistan and UK. We are going to start our second session. This session is going to be chaired by our two worthy faculty members, Professor Dr. Talha Mahmood, who is the Director of Pleural Services and Head of Department of Interventional Pulmonology, Sheikh Zayed Hospital and Federal Postgraduate Medical Institute, Lahore, Pakistan. And Professor Salman Ayaz is going to be our other chair, who is the Professor of Pulmonology and Critical Care in Services Institute of Medical Sciences, Lahore. I'll hand over the mic to our worthy chairs to introduce the speakers, and they can also take the questions from the participants. And I'll be giving last 5 minutes checks during the talks. Over to you, Professor Talha Mahmood.
Good evening, ladies and gentlemen. Thank you very much, the organizers, for inviting me here to chair the session on an update on the pleural diseases. This is session number 2, and we have got 2 speakers. I am Professor Talha Mahmood. I am Professor of Respiratory Medicine and Pleural Diseases at Sheikh Zayed Lahore. So going to have two scientific presentations today. I'd like to introduce my co-chair, Professor Salman Ayaz, who will be introducing himself, and he will also be introducing the first speaker, Professor Salman Ayaz.
Thank you very much, Dr. Talha Mahmood. I'm really grateful for the KEMCA UK for organizing this wonderful and very professional and informative talk over here. Regards to all the respected colleagues and senior and VC KEMU. I'm Professor Salman Ayaz, already Dr. Talha has introduced. I'm working as Chairman Pulmonology and Critical Care at Services Institute of Medical Sciences, Lahore. Our this second session, the first talk will be about malignant pleural effusions. MPEs, though prognostically it puts the patients on the lower side, but still we have a lot to offer these patients in terms of palliative care, especially the patients having good functional status. And the Lent score is a good guide about the treatment options and prognostication, and then about the pleurisy. So our first talk will be all about this. And let me introduce our first speaker. He is Professor Jurgen Herre. He's a consultant interventional pulmonologist with special interest in pleural diseases. Currently, he's working at Edinburgh Hospital, Cambridge, UK. So thank you very much, sir. Over to you, please. And we will take the questions in the end for 5 minutes. Thank you. Sir.
Hi, good evening. Thanks very much for the invitation. I'm going to talk about malignant pleural effusions. I'm going to take a slightly more practical approach because this is, as already mentioned, a predominantly palliative problem. There are some trials, and I will speak about them, but a lot of this is really just sort of practical problem solving. One of the things I will also mention is that the reason why I have interventional pulmonology at the bottom here is that, as well as being a pleural service, a large pleural service, we're a very large interventional bronchoscopy service. And we also run the largest tunnel peritoneal drain service that I'm aware of in the United Kingdom. So what I want to cover today is really just sort of briefly about the causes of malignant pleural effusions, how they form, how they present, what sort of imaging approaches are useful, and then the diagnostic interventional approaches we will use to deal with these, and then managing recurrent pleural effusions, which in which we'll also discuss pleurodesis. Right, so these data are predominantly UK because we have good data for this, and there are about 50,000 malignant pleural effusions per year in the UK, sort of 1 in 1,300 of the population. And they're predominantly metastatic in nature. And the tumors most likely to cause effusions are lung cancers, breast cancer, and lymphoma. So they're the ones that are associated most frequently with this, although they're not necessarily the commonest overall cause. Mesothelioma is really very commonly associated with malignant pleural effusion, but it's quite a rare cancer. And the other cancers that are commonly associated with these are tumors that are sort of locally metastasized from the stomach or distally from kidneys, ovaries, and colon. And something to think about is, and one of the reasons why I mentioned this is because we involved a lot of peritoneal work, is that malignant pleural effusions and ascites often occur together and often benefit patients to be co-managed. Okay, sorry. So how do the tumors cause effusions? Now, it's a very simple equation: more fluid in, less fluid out, and you end up with a net gain, and that becomes an effusion. The working hypothesis is that tumor cells metastasize to the visceral pleura through the bloodstream and then invade the visceral pleura, generate a low-level effusion, sort of seed into that effusion, and then stud the parietal pleura, and in combination lead to a leak and an effusion. They could, of course, also invade through lymphocytic spread, sort of carcinomatosis process, and it's when the production overwhelms the clearance, and you can think of it a bit like sludging up. So you have a lot of malignant cells in the pleural fluid that block up the sort of drainage ports at the base of the lung, and then you get a net accumulation. So the reason why I put this slide up is that everybody knows about Light's criteria and about the various types of effusions. And malignant effusions usually are exudative and less frequently chylous. But because they don't read the textbooks, and many patients have comorbid conditions such as liver failure or cardiac failure, you can actually have a transudative malignant effusion. We see these rather frequently now. And one of the markers that does help there is a high LD, because that tends not to happen in conventional transudative effusions. That's a warning before you got your cytology back, and sometimes cytology can take a while to return. So how do people present generally? It's really commonly asymptomatic. And the reason why I put up the two pictures next door is that the first slide is of a young guy who had a sarcoma, and this X-ray was taken, he was discharged, and the X-ray hadn't been reviewed. We called him back, and the next day, and he'd been out partying the whole night without noticing breathlessness, and that's a whiteout. So young, otherwise physiologically good people can cope with effusions very well. The other picture is of a middle-aged gentleman who was very fit, ultra athlete, and he really just noticed it toward the end of a very long ride, and that's how he came to our attention. And of course, you can have chest pain and breathlessness, but they're not necessarily present. Persistent cough can also occur, and then more often than not, systemic features such as weight loss and other features of malignancy. Orthopnea is less common. So how do we image effusions? Now, this may vary slightly across the globe, and it may be slightly different for you, but we here rarely diagnose them clinically now. Most commonly, someone has an X-ray because they've come into hospital and they have an effusion, and that's how it comes to us. In the UK, more often than not, that's followed by a contrast-enhanced CT scan, which, again, may not be that commonly available in Pakistan. Occasionally, it comes to light because someone has an echo or some other imaging investigation for an unrelated problem, and someone notes an effusion. So thoracic ultrasound, which is our primary work tool in pleural services, is really the initial diagnostic tool used. And I've put an aside there is that CT can miss subtle pleural thickening really rather frequently. And when we do thoracoscopies, often note pleura that are quite studded that are reported as normal on a contrast-enhanced CT scan. So for those of you not familiar with it, and I imagine most of you are, ultrasound point-of-care imaging is really important as a tool in pleural work, and in fact in lots of other medical work these days. And it's very useful, especially if your CT is not available 24 hours a day or easily when you're working. And the dynamic images are really quite good, although they're slightly operator dependent. And they can show you lots of anatomical detail that CTs and X-rays don't capture, and I'll show a few pictures later on. It allows for assessment of diaphragmatic movement, diaphragmatic position, nodularity. When you put your needle in, you can avoid structures you don't want to hit. And you can also characterize the fluid and also the underlying lung parenchyma rather well. Unfortunately, however, you can't see through bone or air, so sometimes people who had a pneumothorax can be slightly more tricky. So before you put a needle in, you really ideally need to have an ultrasound available so you can pick your spot. And the traditional concept of a safe triangle and so on really doesn't apply if you have point-of-care imaging available. You go to the best, most suitable spot where there's adequate fluid depth rather than worry about the so-called safe triangles and so on, because they matter much less. So I'm going to show a few sort of common imaging findings. For those of you not familiar with ultrasound imaging, this is a normal pleura. There's a lot of big effusion here, but the pleura itself is normal. A little white line at the top, just below the sort of plus, if you like, is the pleura. That's normal, thin, sliding pleura. The pleura gets much thicker, and the image on the left shows a nice thick pleura. And I'll play a brief video here where you can see the pleural thickening is really quite marked in this patient and quite fibrotic. And the lung is sort of stuck to the diaphragm. You very often get this when there's very fibrous pleura, lots of bits are stuck to each other. Here's another one, which another sign which we find very useful. It's not obviously being tried, but it's something which we find really useful as a way of describing. The CT of this patient is on the left. We call this a swirl sign. When you see this sort of swirl of little particles that are rotating around, that is almost invariably malignant. It's very, very rare to find another cause for an effusion that looks like this. What you also need to think about is other effusions. This patient came in extremely breathless with a big effusion on X-ray, and we were asked to drain it. When I scanned this patient, I found a tamponading pericardial effusion, which we then drained, which was the cause of the breathlessness. The pleural effusion was then dealt with later on. So you may want to prioritize things slightly, and the ultrasound can help you to do that. Here is another effusion, which just shows you slightly different modalities that we use. So the CT shows you relatively little of the effusion if you look at the bottom. The ultrasound shows you more of the effusion and some of the lung structures. And when you put a telescope inside, you can see much more detail. So these are the sort of three modalities that we use predominantly in our work. Sometimes the pleural can get in your way. This is an image of someone who has extensive pleural plaques, didn't have a malignancy, but these are asbestos-related pleural plaques and calcifications that can interfere quite significantly with your ability to image this chest. So how do we tackle these effusions in a way that we can get diagnostic tissue from them? All right, so the important thing is to decide whether you're going to sample them. And unless you've got a really good reason to, I think you should always put a needle into an effusion, especially if there's any suspicion it's malignant. You get a result relatively quickly. You can make lots of sensible decisions based on a simple diagnostic sample. You may not want to put a needle in if it's clearly a resolving effusion. You've got organ failure, heart failure, kidney, liver failure that you've not optimized yet, and there's uncorrected coagulopathy. Those are reasons of not to sample. I would bias towards a therapeutic aspiration, by which I mean a large volume aspiration. If someone is compromised from a ventilation point of view, there's evidence of tamponade, they have sepsis, or there's a malignancy and you wonder whether this underlying lung will re-expand. And that's quite a useful test, because if you take a significant volume of fluid out in the lung, shows a trapped lung, you will know that you have a different decision to make if you're going to go with the telescope or tunnel drain or whatever else you're going to do next. I put the tests order on here just as a reminder, because it's worth doing the full set each time, even if you suspect it's malignant, because the glucose levels are often low in malignant effusions. The LD is always useful, and in your case, sending TB is a useful additional diagnostic tool. In our setting, we need 30, 40, 50 milliliters is really optimal to make a cell block from. And if there's any suspicion of hematologic malignancy, sending a HODS at the same time will give you a lot more information. So this is a paper from Nick Maskell and co. That shows the reliability of pleural fluid cytology. And this impacts on your decision to do further investigations. So you can see if you have an ovarian cancer or an adeno lung or a breast, you have a very high yield of positive diagnosis. Gastrointestinal, slightly wider. When you go to hematological, squamous lung, small cell, meso, and others, the yield is very much lower. So if you don't get a diagnostic yield, you're going to want to take the next step and say, well, am I going to biopsy this in some way? And this is where ultrasound-guided biopsies and medical thoracoscopies come in. So this is how we diagnostically aspirate. Simple 60 milliliter syringe, we take a full syringe. We don't, in our hands, use anesthesia because it's not particularly painful and it's very quick. And we will do the investigations I previously mentioned. This, I don't know if it's available to you, but this is our workhorse. And this is how we do most of our aspirations. It's an over-needle catheter. So you pop the needle in, you give local anesthetic, pop the needle in, pull the needle out, leave this pigtail catheter, this blue pigtail catheter behind, and you can drain fluid out. The maximum I've ever drained is 4.5 liters, patient tolerated it well. Patient tolerance, of course, allows you to limits you how much you take out. However, in some patients, we find that entraining some air relieves the pain if you happen to have some negative pressure pain. This gives you the chance to do a few things that you can't do with just a diagnostic aspiration. The first of them will reveal a trapped lung, which you can't do if you only take out a small volume. It also allows you to establish how quickly the fluid refills, because that impacts on whether you're going to want to think about an indwelling drain or whether you think, okay, we can do a pleurodesis or a thoracoscopy or something else down the line. Chest drains for malignant effusions, of course, they're a wonderfully useful tool. However, you want to decide before you're going to go into an effusion whether you're likely to want to pleurodese it in this particular setting. So if you don't have a diagnosis back yet, you may want to sit tight if you're not sure it's malignant. So in that case, you may want to just do a large volume aspiration, wait to get your result, and then make a decision. If you put a drain into a patient, you're likely to drain them to dryness, and then you're going to have to leave the drain in long enough until you know your diagnosis if you want to do a pleurodesis. Or if you pull the drain out, well, then you've got a second procedure to do. So it is a slightly challenging point. That's why we use chest drains much, much less than we use aspiration, IPC, and thoracoscopy. So this has been mentioned already earlier on, and it's one of our great bugbears, is that radiologists seem to really struggle with the concept of what a trapped lung is. And these are just a few pictures. This is, along with is visceral pleural thickening, you've removed fluid and it can't expand. It doesn't mean it won't re-expand, as the as yet to be published meso-trap feasibility study shows that a significant proportion will re-expand if you keep the space empty. However, it initially doesn't. Now, this is not a visceral air leak in most cases and doesn't need to be acted upon. I've got a picture here of someone who was drained, aspirated. You can see this lovely lobulated appearance, which is very typical for a trapped lung, a lung that's been down for a period of time. And sometimes people get pain from this, from the negative pressure. Sometimes they get pain from the sort of hanging hilum, if you like, where the lung is no longer floating on a fluid bed. Most of the time, it isn't particularly painful, especially if you can entrain some air to relieve pain when they have it. Here's just a nice series from a patient who's currently being managed by us that shows that over time, the lungs get more and more trapped. This is a breast malignancy over a period of 6 months. Despite the trappedness of this lung, the reason I put it up is that she, on the last picture down below, she had significant sustained relief from removing the effusion that had filled up that space, despite the trapped lung. So it's always worth trying it. What we did in her case, because she gets pain from the sort of negative pressure, we just let in some air and you can essentially drain it to dryness, and she's pain relieved. The lung is tethered, so it doesn't really hang off its hilum. A sign, again, that's not been described in the literature, but on a CT, if you see this, what I call it, for want of a better word, a B sign, the sort of curved lobular structure, these lungs are inevitably trapped. And you can anticipate it up front. So you then may want to modulate or prepare for that when you're going to drain it. So the options for managing recurrent malignant pleural effusion, this is where some of the relevant trials I will briefly discuss. So what can you do for these people? The first, most simple thing is you can repeatedly therapeutically aspirate them. And this is for people who have very slow accumulating effusions that are not particularly bothersome, and particularly if they're about to undergo chemotherapy or ongoing chemotherapy, and you don't want to leave a tunnel drain in there, and they've got perhaps a trapped lung that doesn't re-expand, you're worried about achieving a pleurodesis. An indwelling pleural catheter is the next alternative, in this case without TELC, just to keep the fluid empty. Keeping in mind that if someone has chemotherapy, especially if they become neutropenic, there is a significantly elevated risk of developing pleural sepsis. The next step up you can do is IPC with TELC, and I'll briefly discuss the IPC trial in a minute. The next alternative is medical thoracoscopy plus a TELC poudrage versus intercostal drain plus TELC. That was the HAPS study, which we'll also discuss. And then there's the TACTIC trial, which is currently still recruiting, essentially compares thoracoscopic poudrage and indwelling catheter versus poudrage only, a thoracoscopic poudrage only. And that's not yet closed, so I can't give you the interim results yet. And then I'll briefly talk about ambulatory thoracoscopic pleurodesis, which is something we've been doing for a number of years and works rather well. So IPC Plus is a trial that published in the NEJM in 2018. I took 154 patients and essentially randomized them to an indwelling drain or an indwelling drain followed by TELC 2 weeks later, once you'd seen the lung had expanded nicely. And as you can see from the data, the pleurodesis success rate is about double as good. And thus, for someone who has a pleural indwelling catheter that's been fitted and who has an ongoing effusion that hasn't autopleurodesed, adding some TELC is a reasonable option and works. The TAPS trial, as I've mentioned already, is thoracoscopic poudrage versus an indwelling, chest drain plus slurry, the sort of standard versus thoracoscopic version. And what this showed is that they're equally successful. 78 versus 76%, and they're equivalent depending on your service availability. But the study didn't come out strongly in favor of one or the other. I mentioned ambulatory pleurodesis here, and this simply put our paper up because there isn't anything else in the literature. There are 2 smaller studies which were done as inpatients some years ago that showed the same thing. But this is real world patients that have been not selected. They've come in, they needed a pleurodesis, we did a pleurodesis in an ambulatory fashion. So we put them through a thoracoscopy, put an indwelling drain in, gave them TELC, and sent them home. 87% of them went home same day, 3.5 hours after they came in. And we achieved a successful pleurodesis at 6 months, about the same level as TAPS did, slightly less at 3 months. So the pleurodesis success rate increases. We got a diagnosis and we had no complications related to it. So it works quite well. For those of you not familiar with thoracoscopy—
Last 5 minutes, please.
Okay. We are able to see very nicely what goes on in the chest. You can assess the pleura, you can do biopsies. I won't go through any more detail on that, otherwise I won't have a chance to, sorry. What's useful, what we do is we always mark both the tunnel drain site, tract, and the thoracoscopy site. Diaphragm is down here, the head is at the top. We always enter the pleura a space or so above the diaphragm, so you have a reasonably clear access, and the eyepiece is always placed above that so that you have the diaphragm not later on coming up and impinging the drain, so you end up with pain. In our case, we put people on suction straight after thoracoscopy to get the lung reinflated as rapidly as possible, and then send them home after a couple of hours. Najib has already mentioned for infections, ultrasound-guided biopsy. It is an alternative to thoracoscopy for people who've got thick pleura, who have frail tethered lung, and who have a minimal fluid volume, and they've got a good diagnostic yield. Unfortunately, of course, you can't achieve fluid control, and very often the sites are inaccessible. And thoracoscopy can get to really small effusions. I've just stuck an example here. I went in over here, really small effusion. This is, I've got in many, many smaller. You can get access to the pleura and get good biopsy samples. So indwelling drains, they're really good for this, for forming pleural effusions, with or without thoracoscopy, in whichever setting. They're really good for end-of-life palliation. They allow patients to be at home and drain themselves. They don't have repeated interventions. They promote independence. They get people living outside of hospital, and they're quite good for people have mentioned before, for organ failure effusions as well in a palliative sense. What do you need, however, to be able to do them? And this is quite important. If you're going to put in tunnel drains, you really need to have people in primary care who can manage them. You really need to have people in ambulatory care who can deal with problems and complications when people come in rapidly. You have reliable suppliers of the accessories in the community, otherwise someone gets stuck with a drain that they can't drain. You really need to have people in local hospitals who can manage them expeditiously. And you need a follow-up process, because these are not fit and forget. We remove half the drains we put in. These are the 2 drain suppliers we have. You may have others, but these are the predominant suppliers that I'm aware of. So we've discussed their use. The thing you need to do prior to popping an IPC in is ideally have a large volume aspiration operation just to figure out if the lung can re-expand. If the lung can re-expand, they may be better off with an intercostal drain and slow pleurodesis or a thoracoscopic pleurodesis. That's much faster than even the IPC plus approach takes. It's really worthwhile scanning the chest extensively and figure out where you want to put the drain. You don't want to put it at the back when people sit and lie on. You want to get the drain more around the front so that they can access it and see it if there's any leaks or hemorrhage or cuff starting to come out. Think about the body shape. Don't put it into body fold. That's where sepsis gets in. Think about women if they wear bras, where the bra line does not lie on the exit side because you get pressure sores. Very thin patients, put it into the intercostal space, because if you cross a rib, you get an erosion over the rib. So you have to think a little bit harder about where you're going to put this drain and how you're going to manage it over the length of the remaining life of this patient. And that could be a long time. I had a mesothelioma who had draining for 4 years and survived that long with the drain. The complications specific to IPCs are really, the infection is really quite low in these people. And if you do have an infection, very often the normal antibiotics and some TPA and DNAs will deal with the problem. You don't necessarily have to take the drain out. Protein and cell loss really is an issue for the hydrothoraces, which we have a lot of experience dealing with, but not really in malignant effusions. Dislodgement is an issue early on if people are not careful. Blockage, occasionally with tumor ingrowth, but you can often unblock a drain with fibrinolytics or flushing them. Loculation, again, sometimes occurs, and you can break it down with TPA most frequently. Drains in sarcomas, I would say be careful. They tend not to work. The sarcoma just organizes very quickly around the drain. Drain pain sometimes occurs, and sometimes it's because you've got it too low and the diaphragm pushes up against the drain. And erosion of the cuff, as people get more and more hectic, the cuffs erode. So if someone's looking like they're wasting, put the cuff in a little bit deeper. The cuff should be near the exit site, but the depth can be a little bit deeper if someone is likely to waste. Pleurodesis, this is how we do our pleurodesis. So this is a poudrage kit. There's a little puffer on the end of it for thoracoscopy. On the right, I've got a slurry kit. Now, this is how we create a talc slurry. You put saline on the one side with some lignocaine and talc on the other through a syringe, and you pump it backwards and forwards. Gives you a wonderful, consistent slurry, rather than trying to put it into the bottle and shake it up, which doesn't work because it doesn't create a very good suspension. And as sort of an aside point, sometimes people have got pleural effusions that are malignant that don't drain very well. And I've just
please.
Yep, it's my last slide. A couple of papers I've mentioned that you can liquefy this with enzymes, sometimes with hyaluronidase, and it works rather well. I've put up the management algorithm which the BTS has got, which we're currently is being updated and should be released fairly soon. But I've covered most of this in the approach. I'm happy to take any questions.
Thank you very much, Dr. Herre, for this very elaborative talk about MPE. This TAPS trial is quite convincing for the use of IPC plus TELC, but at times, for the diagnostic purposes, we need to use fluoroscopy. So what's your, impression about the ultrasonographic sensitivity to pick small pleural-based nodules so that we can avoid this more invasive procedure?
So if I understand you correctly, you're talking about ultrasound picking up small pleural nodules that you can then biopsy percutaneously. You can do that.
Yeah, that's what
you can do that if they are between the ribs, but a lot of the time you just can't get to them because they're at the back, covered by the scapula. If they're low down, you might be able to get them posteriorly. So it depends on where they are. I mean, that's why it's worth having a look. CT is the best way of getting at them because you can have a look at the whole of the pleura, and CT-guided biopsy is usually a better tool for biopsying nodules. But if they happen to be in the intercostal space and you can see them on ultrasound, yes, absolutely, a true cut biopsy is as effective. The problem is that usually you don't deal with a fluid at that point. So if they don't have an effusion, you anyway have to find another way of biopsying. If they have an effusion, pleuroscopy or thoracoscopy, as we call it, is a much better option because you get a much wider view. And what's quite useful is we always biopsy 2 or 3 different lesions, not one. So you get the heterogeneity of the tumor available, especially if you're going to go down the genomics pathway, because the tumors, the different metastases, some, especially if they look different, can have slightly different genotypes, and that can impact on what treatment you can offer.
Right. Thank you very much. So there is a question from. There is one question, sir.
Yes. Thank you very much, Jurgen, for a very elaborative talk. I just want to have your quick comment on how you can figure out that on the pleuroscopic appearance.
Yeah.
How can you figure out that the lung is trapped? Sometimes you have a lung that appears blue, that appears diseased, and it expands very well on the chest radiograph. But sometimes you have an overall healthy looking lung on the pleuroscopic image, but still it doesn't expand well. So how can you figure out on the basis of your pleuroscopic findings that the lung is trapped?
So that's genuinely difficult. The thing that I have found to be the most predictive in all the thoracoscopies I've done is if the lung is covered in that usually extends onto the pleura as well, a clear sheen of white fibrous tissue. So you cannot see the underlying lobules on the lung. And you get a sort of rounded appearance, particularly if there's some adhesions as well. Those lungs tend not to expand. If you can see the lobular structure of the lungs, especially if you see the anthracotic patterns on the lung surface, it's likely to expand. And the ones that don't expand may just need some time, because sometimes the lungs have been compressed for a long period of time and they get sort of internal adhesions. But we conducted a feasibility study called Mesotrap, where we looked at trapped lungs. They were trapped, as I've shown on the X-ray, after thoracoscopy. So there's clearly trapped lung. And we put a tunnel drain into them. And when we brought them back in order to get them listed for a pleurectomy, most of them had re-expanded 2 or 3 weeks later. So it just sometimes it just takes time. So I think if the lung surface is normal, the chances of getting re-expansion is actually very good. If the lung is very thickly covered, then it's much less likely.
Another important question.
Thank you very much, sir.
When you have put in the chest drain after doing a medical thoracoscopy, and the still lung is not expanding well to the chest wall, and you apply an external suction to a maximum, how long should we wait? Well, how long should we wait before we declare that this lung is not going to expand because of the risk of the infection, the empyemas that can further worsen the quality of life of the patient?
So in the ambulatory pleurodesis paper I mentioned, what we did is we didn't worry about the trapped lung. We gave them, in this case, the case that we did, just a couple of hours of suction, see if the lung would expand. Put a tunnel drain, had a tunnel drain in, and had the tunnel drain drained every day at home. And that negative pressure on a daily basis got re-expansion in 80% of the patients. So we got re-expansion, and for those who didn't re-expand, you need to control the fluid anyway. So you need a tunnel drain. So it dealt with the problem both ways. So most of the time you just need time. And I wouldn't do it as an inpatient, not with a normal drain, because the risk of infection is way too high. The tunnel drain is much better. So you can either put in a tunnel drain, take out the normal drain and apply the suction through a tunnel drain, or the tunnel drains are vacuum bottles that you attach, and they basically evacuate, give you a negative pressure every day when the person drains it. So and that gives it a nice long period of time to re-expand. That was very, very effective. And the tactic, so the ASAP trial showed the same thing.
Thank you very much, sir. 2 questions, sir, are related with the intrapleural question. Yes. Two other questions, if you want to allow, or sir, two questions are related with the use of intrapleural catheter. First one is the use of prophylactic antibiotics before we are using this IPC, and second one is the role of analgesia, especially in the trapped lungs, while we are using IPC.
Okay, so I'll take the first one. We always give prophylactic antibiotics, but just a single dose at the time of insertion, or preferably prior to insertion, so an hour before. For malignant effusions, if the person has also got organ failure, such as liver or other, we have a more transudative effusion, we tend to give a week of antibiotics to minimize the risk, because they have already got immunocompromised, tend to be the hyperproteinemic, they also tend to have low immunoglobulins and so on. So that's the practice there. So we always give it. And for the ones we do thoracoscopy, we always give it during thoracoscopy anyway. So for those people, we don't give additional prophylaxis. Sorry, second question was about
the analgesia.
Analgesia, yes. So
especially in the trapped lung.
So for trapped lung, analgesia is really rather ineffective. So what we do when someone has a trapped lung, and I mentioned it earlier on, is entrain some air. And if someone has pain, so trapped lung is only painful when you have negative pressure. So on the channel drains, you have a very, very nice control of the suction. So the moment people get pain, we stop. We tend not to go beyond that. Just that's the point at which you can suction. You have two options at that point. And with the suction bottles at home, you can't do it. If the patient comes to the hospital, which is what we sometimes do, you can disconnect the drain, let some air in with the connector, and then give it a bit of time and apply some more suction to remove fluid and alternate those two. If the person has pain, something that works really well is just, so they've got these sort of connectors that you can connect the suction, the drain, tunnel drain to a normal chest drain bottle. Just connect that and open the valve and let some air in. The pain's instantly gone. So
thank you very much,
so that's
Dr. Herre.
Thank you very much.
Very grateful.
We'll request the speaker to answer the rest of the questions in the chat as we're running out of time.
Let me introduce the second speaker of this session, Dr. Mohammad Tufail. He is a consultant interventional pulmonologist, and he has a special interest in pleural diseases and lung cancer. He's from Glenfield Hospital, University Hospital of Leicester, NHS from UK. And we invite Dr. Mohammad Tufail to start his presentation.
Sorry, thank you very much. I will be there very soon. I just need to get the screen right. By the way, thank you very much for the nice introduction. And let me share my...
Well, we can see your screen. We can see it.
Can you?
Yes, we can.
Oh, that's good then. Okay, let's start then.
You can just start with the slideshow.
Thank you. So thank you very much for the invitation and a nice introduction. So I have been given the task to talk about benign pleural effusion, which is really a very extensive topic, and I will try to do the justice as much as I can. So I will briefly talk about common causes of benign pleural effusions and their treatments. So benign pleural effusions are not that benign. So that is the argument I'm going to make. So as you know, for malignant pleural effusion, the prognosis is not that good, but so for benign pleural effusions. As you can see from work of Professor Najib Rahman and Professor Nikmas, really, we should be really proud of them. Over the last 1 decade or so, they have led many randomized controlled trials for management of malignant pleural effusion, but that does not mirror in the benign pleural effusions. And we can see that this is all due to multifaceted nature of these effusions and many specialties involved. And sometimes it is difficult to get the patients as well. So I will argue that benign pleural effusions have got the, if not the same, but quite worse prognosis, as is evidenced by this study in predictors of mortality in non-malignant pleural effusions. You can see that in this observational study, in cardiac failure, if you have got pleural effusion, your 1-year mortality is 50%, for hepatic failure, 25%, and for renal failure, 46%. So really, we have to look after these patients very well to improve their quality of life and try to improve their prognosis. And also, you can see there are British Thoracic Society guidelines, American Thoracic Society guidelines on malignant pleural effusions, but no guidelines exist on benign pleural effusions. So I will whiz through some of the common causes of benign pleural effusion. As you can see from Bristol, this audit showed that pleural infection is the most common cause of benign pleural effusions, which has already been covered by Professor Rahman, and then followed by congestive cardiac failure, idiopathic pleuritis, and so on. So congestive cardiac failure, 2/3 of the patient with CCF will have some sort of pleural effusions. They are usually small to medium in size, and they tend to be bilateral. But if there are typical features of CCF clinically, and you have made the diagnosis of congestive cardiac failure, the effusions are small to medium size, and they are bilateral, just treat them without a diagnostic thoracocentesis. If there are atypical features, or clinically you are suspecting some coexisting pathology like malignancy, you have to go ahead with further investigations. And usually for heart failure, if we are going to perform thoracocentesis, I usually tend to perform therapeutic thoracocentesis rather than just a diagnostic, unless I'm going to plan thoracoscopy. So this is the case when I was a fellow a few years ago, just to demonstrate the acute management of congestive cardiac failure. So this is a 74-year-old gentleman who was on 14th of July with acute pulmonary edema and hypoxic respiratory failure, as we had missed inferior STEMI, and that inferior STEMI led to development of cardiac failure. So he had bilateral pleural effusions, so the team decided to perform therapeutic right-sided pleural fluid aspiration. They removed more than 2 liter fluid. No, this patient was on Plexane, on dual antiplatelet therapy as well. So following thoracocentesis, they performed a chest X-ray. There was a small right apical pneumothorax, not a big issue. And then they decided to perform therapeutic aspiration on the left side as well. And no, this patient has good acute pulmonary edema. They are desperate to drain each and every drop from the pleural space. So this time it was heavily blood-stained fluid, and thankfully there was no pneumothorax. And then next day, a patient deteriorated significantly with hypotension, hypoxia, and oliguria, developed acute renal failure, and chest X-ray showed large left-sided pleural effusion. And this patient was rushed to CT scanner after stabilizing him to look for any bleeding site and whether we can embolize it or stabilize the patients. So this is the outcome. So this is the CT scan taken just before patient had cardiac arrest. And the CT scan shows large hemothorax in the left pleural cavity. So I will argue we don't need to drain each and every pleural effusion when it comes to CCF. Please leave it to our cardiology colleagues to treat it medically. Yes, we can drain it once patients are out of the acute phase, and if they persist, then we can look for drainage of the effusion. This is another patient only last month in our unit, typical case of congestive cardiac failure, 89-year-old gentleman who was admitted in HDU. You can see there is a clear-cut evidence of congestive cardiac failure on this chest X-ray. So they decided to drain the right-sided effusion. And you can see there is a big pipe going into the pleural space, 32 French chest drain, complicated by surgical emphysema. And it drained about 300 ml of fluid. And when they removed the chest drain, patient developed large right-sided pneumothorax. So for pneumothorax, they have to put another chest drain to drain it. And you can see that if you compare this last chest X-ray with the first chest X-ray, obviously patient was getting intravenous diuretics as well. The left-sided pleural effusion has resolved with the effusion, though right-sided has resolved as well, but it was damaged by unnecessary pleural intervention. So through these two cases, I can say that during the acute phase, please be careful putting chest drains in these patients. Post-cardiac injury or Dressler syndrome, it can develop after any kind of myocardial or pericardial injury, which could be due to many causes like angioplasty, pacemaker insertion, or surgery. It is typically characterized by fever and pleuropericarditis in the weeks after trauma to the pericardium. It is immunologically mediated, hence it responds very well to NSAIDs and anti-inflammatory medicines, and sometimes we have to use steroids to control this. So clinically, you will find pleural rub in these patients, almost all of them. Post-CABG pleural effusion, almost all patients after CABG will develop pleural effusions. And usually they are small, left-sided, and self-limiting. And they are probably related to trauma of the surgery and post-operative bleeding. Usually we don't need to do anything for them. If they are large enough and patient is symptomatic, we can drain them. And unlike Dressler syndrome, fever or pain is uncommon in these because they are all due to trauma. They are not immunologically modulated. So most effusion resolve over the period of time. Hepatic hydrothorax, so by definition, is a transudative pleural effusion that develops in a patient who is known to have cirrhosis and portal hypertension. So these are the requisites. Though having ascites is not a prerequisite to make the diagnosis, more than 80% of the patients will have ascites, but not all of them. The effusion is usually unilateral and right-sided. We have got our Vice Chancellor, Professor Mahmood Ayaz with us, and he will know, being a hepatobiliary surgeon, that the diaphragm is on the right side is quite tendinous structure, and on the left side, just above the stomach, it is quite muscular structure. So in this tendinous structure on the right side, there are many pores within the diaphragm. Hence, the pathogenesis, the most commonly agreed pathogenesis is that there's a negative pleural pressure in the pleural space, and there is a massive ascites. And through those pores on the right side of the diaphragm, the fluid is pulled into the space. And this, I can show you the X-ray of the patient. Usually they come with medium-sized to large-size pleural effusion, and sometimes they do come with tension hydrothorax as well. So there are many other pathogenesis are debated, but this is the most commonly agreed upon. So this is a diagnostic algorithm for patients, so any patient who have got cirrhosis and they develop pleural effusion and they have portal hypertension. So you take the pleural fluid sample for analysis, and if it is a transudate based on Light's criteria, and if polymorphonuclear cells are less than 250, you make a diagnosis of hepatic hydrothorax. Now, there is an entity called spontaneous bacterial empyema, similar to spontaneous bacterial peritonitis. So the criteria for that is if polymorphonuclear cells are more than 500 with negative pleural fluid culture, or there are polymorphonuclear cells more than 250 with positive pleural fluid culture, then you make the diagnosis of spontaneous bacterial empyema. So this carries a 20% mortality and has to be recognized early and treated with the broad spectrum antibiotics. Usually the bacteria are gram-negative or even Streptococcus pneumonia, Klebsiella, Enterococci, etc. If it is an exudative pleural effusion, a patient is not on diuretics and look for some other causes of exudative pleural effusion. And but if patient is on diuretics and serum to pleural fluid albumin ratio is less than 0.6, then still treated as hepatic hydrothorax. So this is the diagnostic algorithm. The treatment approach is usually it is managed by our hepatology colleagues to reduce the formation of ascitic fluid by medical treatment, like give diuretics, furosemide, and spironolactone, terlipressin. And now TIPS is a procedure which is quite effective for this, though the operation, which is life-saving and improves the mortality. The only treatment out of these which improves the mortality is liver transplant. So if these patients are suitable for liver transplant, they should be referred for liver transplant. But if they are suitable and they are waiting for a long time for liver transplant, then we should go for a transjugular intrahepatic portosystemic shunt that will decompress the portal system, reduce portal hypertension, and reduce formation of the fluid. We can prevent the transfer of ascitic fluid across the diaphragm. There are series in which surgeons have gone in and they repaired the diaphragmatic defects or even put the mesh there to reduce the movement of ascitic fluid into the pleural space and also perform the TARC pleurodesis at the same time. Or we can drain the pleural space, repeated thoracocentesis, but be careful with these patients, please, as if you continue to drain these effusions, they are at risk of developing acute renal failure. And there is a debate that we should be treating them as the same as abdominal paracentesis. So for every 2 liters of the fluid, you should be giving 20% HAS to these patients so that they don't go into acute renal failure, etc. Or we can obliterate the pleural space by giving secularizing agent like talc is the most commonly used, or even you can use VATS and pleurodesis, as I mentioned before. But for talc pleurodesis, talc or poudrage, if patient has got significant ascites and you don't treat that, the talc will usually fail because there's a constant movement of fluid from the abdomen into the pleural space, and you will not achieve apposition of the visceral and parietal pleura for pleurodesis to work. So this is a proposed algorithm from one of our friends from Florida. So if you have got symptomatic hepatic hydrothorax, so treat it medically. If it becomes refractory, liver transplant is the treatment of choice. Now, if expected wait time is more than 3 months and MELD score is more than 15, childhood score is class is C, or age is more than 60, then you can go for pleurodesis, CPAP, or even put Pleurex chest drain with careful consideration. If no, then put tips and wait for liver transplant. So if I have to say, the liver transplant is the top priority treatment, followed by tips, and followed by sent to us. We can do repeated therapeutic aspirations or even put IPC. So there are these interesting 3 series from surgeons. They in the first 2 ones, they have mentioned 8-year. The first one has mentioned 8-year survival rate in this hepatic hydrothorax patient with liver transplant up to 53%. And Saeed-CPD et al. 1-year survival nearly 70%. So first 2 studies, they even compared the patients undergoing liver transplant in the presence of hepatic hydrothorax and in the absence of hepatic hydrothorax. There was no difference in survival rate. In the third study, they advocated that the patient who had hepatic hydrothorax, they were at higher risk of developing postoperative infections, though their 3-year survival rate was still about 60%. Next common cause of pleural effusion is renal disease. So it occurs in about 7% of patients with CKD and 20% of those who are undergoing any kind of renal replacement therapy like hemodialysis, and complication of peritoneal dialysis as well. About 2% of the patients will develop pleural effusion as well. So the components of the pleural effusion will be the same as peritoneal fluid. And these patients are very vulnerable to pleural infections. Please, in Pakistani setting, I will say, please look for TB in these patients as well. We missed a patient recently whom we thought that it is just all renal disease causing this, but there was another mechanism of TB going on top of renal disease. Pulmonary embolism, yes, it is something which is very frequently undiagnosed. It can happen in up to 30% of the patients, and the pulmonary embolism can cause pleural effusion. Usually it causes pleural effusion on the same size as pulmonary embolus, but it can happen on the other side as well. If you try to aspirate it, so it will be an exudate and blood-stained fluid. So if a patient has got pleural effusion and their shortness of breath is disproportionate to degree of pleural effusion, the patient has got pleuritic chest pain, please always consider PE, because small pleural effusion should not give you very much shortness of breath. Autoinflammatory causes of benign pleural effusion, we do see about a dozen of patients per year where sometimes they present to cardiologists with the cardiac tamponade, really, and they have got both pleural effusion and pericardial effusion. And most of these patients usually have autoinflammatory cause and serositis, which is affecting both pericardium and the pleura. So if it is rheumatoid arthritis, usually it is painless exudate with low pH and glucose, as you all know. In SLE, it is very painful, and SLE can subsequently cause renal failure, heart failure, and PE, which will contribute further to the pleural effusion. And there are other connective tissue diseases like systemic sclerosis, mixed connective tissues, and still disease, which can cause it. In about 1/3 of the patients, in our experience, we never find any cause of this effusion, though they get better. And sometimes we end up giving them NSAIDs, steroids, or even colchicine. Chylothorax and pseudocylothorax, so this is rather a rare cause of pleural effusion. So it's the presence of chyle or milky fluid in the pleural space. It will be rich in chylomicrons and triglycerides. It is all due to the disruption of the thoracic duct, which has got long route from going from the abdomen to drain into the venous system. Trauma and malignancies are the most common cause of it. And sometimes they are mistaken for pleural infection. If you aspirate a pleural effusion, it is milky. You can leave it for about 30 minutes on the bench. On the photo below, you can see that there is a supernatant and there is debris at the bottom of it. So this is empyema, because all the degranulated white cells have gone at the bottom of the bottle. But in the top one, this is a true coil in which all the lipids are soluble in the fluid and they will not sediment on the bottom. So this is a bedside test to differentiate between chylothorax and empyema. So treatment usually is low-fat diet. For how long we should give them? Usually we give them for 6 weeks or so. So thoracic, any leak from thoracic duct usually during this period of time heals itself. In refractory cases, we do send them to surgeons or even interventional radiologists for thoracic duct ligation. We have done IPCs for a selected number of patients for chylothorax. Pseudocholothorax is another entity in it is characterized by the presence of cholesterols, but lacks chylomicrons, and the most common causes are TB and rheumatoid arthritis. So benign pleural effusions secondary to radiotherapy. Now, this is an interesting series of 3 patients. You can see the chest X-rays and the CT scan. So these are patients who are known to have a lung cancer. They have undergone treatment with the radiotherapy and chemotherapy, and during the course of their treatment, they developed the pleural effusion. So in all these 3 patients, they aspirated the pleural fluid. It was negative for cytology. In some patients, they did endobronchial biopsies, and one patient, I think they did pleural biopsies. All came back negative. So during the course of treatment with chemoradiotherapy, if patients develop pleural effusion, it is not always malignant, and we can give the patient bad news. Not really. In these patients, the pleural effusion was probably related to radiotherapy, and these can be treated with NSAIDs and steroids. So please keep in mind, not every pleural effusion is malignant. How we differentiate between benign and malignant pleural effusions? Obviously, pleural biopsies are the gold standards, and pleural fluid cytology is positive in only about 60% of the cases. But there are some CT scan scoring systems. For example, in this study, they have come up with a scoring system with total number of 20. If your score is less than 5, the chances of malignancy are low based on CT scan. PET-CT in differentiating benign and malignant pleural effusion, on its own, it is not very reliable. Just looking at the SUV max of the pleural surface will not help. So in this meta-analysis, they have found the sensitivity up to 82%, specificity 74% at the maximum. But if patient has got other features, like in this patient, pleural thickening, pleural nodularity, really that adds on that non-invasively, you can diagnose malignancy in these patients. But on its own, PET-CT in isolation, I don't think it is a good test to say it is a benign or malignant pleural effusion. And there will be some patients who will not be suitable for biopsies. Obviously, I am not talking about any pleural fluid markers, but there are a few which have been studied. For example, mesothelin has been studied for mesothelioma and carcinoma, embryonic antigen, etc. That can be looked into, but still pleural biopsy remains the gold standard to make a diagnosis. So there is a study going on, a stratified study by Professor Khalid from Glasgow. So you will see that, thank you. So you have to stage the patients properly. There will be some patients with non-small cell lung cancer. Initially, they will have very tiny and small pleural effusion. Traditionally, we have been calling them malignant, but are they really malignant without biopsy? If you call them malignant, they are without any biopsy, they are stage 4 diseases, and are you overdiagnosing malignant pleural effusion? So this trial is going on at the moment. So the criteria is a minimal pleural effusion covering less than 1/3 of the hemithorax, and they are radically treatable and suitable for medical thoracoscopy. So and primary endpoint will be occult pleural metastases defined as non-small cells in the parietal pleural biopsies. So that way we can know whether these small effusions are malignant or not. Usually large pleural effusions are malignant until proven otherwise, but smaller pleural effusion, we have to be careful, call all of them malignant. With the increasing life expectancy and aging population, there will be many patients who will have more than one etiology for the pleural effusion. So in this very nice study, the primary diagnosis was malignancy, but about 30% of the patients had more than 2 causes, 2 or more than 2 causes of pleural effusion. For example, a patient who develops lung cancer and they have got heart failure as well, and they develop hypoalbuminemia due to cancer. So all these mechanisms are contributing to the development of pleural effusion. So we have to keep in mind that in some patients, there is more than one cause of pleural effusion. Treatment of recurrent benign pleural effusions, as we have mentioned, it is always the treatment of the underlying cause. Repeated therapeutic aspirations, you can put IPCs, can even fluidices or shunts. So this is indwelling pleural catheters you all have seen in the previous talks. I will not go in much detail of these, but they can be used. So this is a big meta-analysis, including 13 studies and 325 patients by Manali Patel, in which they inserted IPCs in about 162 patients who had cardiac cause, hepatic hydrothorax, cardiothorax, even for empyema. So there are varied reasons they have put IPC in these patients. And you can see the spontaneous fluidisis rate is about 51% in these patients. Estimated rate of complications, any complications, about 17%. Obviously, skin infection and empyema, they are the most common complications of IPC. So we have to be very much aware of those. Obviously, IPCs have been studied very well in the malignant pleural effusion, but not so in benign pleural effusion, but we do have some data. This is a very nicely done trial, reduced trial. It is a randomized trial for indwelling pleural catheters for refractory transudative pleural effusions. So it was done, I think Professor Rahman is the part of the team, and Dr. Walker and Nick Moskal. So multi-center randomized controlled trials, patients with the refractory transudative pleural effusion was randomized to either undergo IPC or therapeutic thracocentesis, and they measured the primary outcome by VAS score from 1 to 100, and there was no difference in breathlessness at 12 weeks. So these are the results. So it is a kind of negative study, though the patients who had thracocentesis is associated with fewer complications, and IPC reduced the number of further invasive pleural procedures and the secondary outcomes. This is a study done by surgeons in which they took patients with heart failure for IPC insertion, indwelling pleural catheter insertion via thoracoscopic tall poudrage. You can see the morbidity in surgical group was much higher. I will not recommend sending recurrent transudative effusion patients to surgeons to do big VAT surgery and tall poudrage. Rather, we can do tall poudrages with the success rate anything between 30 to 70%. Shunts have been old style treatments. In this on the right side, you can see a large pleural effusion in which they have put pleurovenous shunt. From the pleura, you tunnel a shunt which goes from the pleura, goes into the right subclavian vein, and you can see from these dots, white dots, and the effusion is gone into the venous system. Obviously, you need to have a pump which patient presses, and the pleural fluid drains into the venous system. But there are serious complications of air embolism in these patients. We have to be very careful. And interestingly, the next chest X-ray, if you see carefully, this is a patient with small pleural effusion. This is one of my young patient who has got hydrocephalus, and they have put ventriculopleural shunt. So it is other way around. So there is a CSF draining into the pleural space. So that is an interesting one. This is a patient in which ventriculoperitoneal shunt had failed, and they decided to shunt the CSF into the pleural space. So it can be other way around, but usually we don't use these treatments very well. So in summary, benign pleural effusions are associated with high morbidity and mortality. They are not as benign as they look like. 50% of the patients with heart failure will die within 1 year, and treatment of underlying cause and drainage for persistent pleural effusions. And benign pleural effusions are manifestation of several diseases which involve several systems. So really, it is a multidisciplinary approach among respiratory physicians, cardiologists, gastroenterologists. It's not a one-man job. And indwelling pleural catheters have got promising role in the management of these ones and improving the quality of life and freedom from repeated interventions in selected patients. Thank you very much.
Thank you very much, Dr. Tufail, for an elaborative talk on the benign pleural effusions, which are not uncommon in any part of the world. And to the audience, I must say that in Pakistan, we have pleural effusions in patients who apparently appear to be transudates, but there may be an underlying other pathology, like a patient who has lung cancer and who has renal failure and who has congestive cardiac failure, and now the patient has a pleural effusion. So I think one of the messages is that when you see transudates of renal origin cardiac origin or hepatic origin, and they usually do not respond to the diuretics, then we should consider another differential diagnosis. Like in one of my patients who had a large pleural effusion on left side, ascites, and hepatitis C positive. He had a hepatic hydrothorax, and it was an isolated left-sided pleural effusion. And when we tapped the pleural effusion, it was an exudative lymphocytic pleural effusion. And we thought that this could be due to an underlying disease like malignancy or tuberculosis. And we did a medical thoracoscopy, and the pleura was studied with multiple whitish patches, and the diagnosis was consistent with tuberculosis. So it was initially an exudative effusion, and then we put in the chest drain. It drained only around 100 mils in the next 24 hours. And after that time, every day it started to drain more than a liter. And when we did reanalysis of the fluid, it turned out to be transudative. It was ascitic fluid that was turning up into the pleura. So we removed the drain not to get it infected. So sometimes you see dual pathologies in patients who have a predominantly transudative effusion. Similarly, the uremic pleuritis in over part of the world, we see a lot of patients who are on end-stage renal diseases. Typically, they present with transudative effusions, but sometimes long-standing effusions of renal origin, they turn out to be exudates. And of course, when you have tuberculosis as an underlying disease, then we should rule it out by doing a pleural biopsy. And we have done medical thoracoscopies in patients with end-stage renal diseases and found tuberculosis. Or many of the times you find uremic pleuritis, which presents as fibrinous pleuritis, and many of these patients, they actually require pleurodesis because they have got very, very resistant effusions, and they do not respond to diuretics and even to the adequate dialysis. Even if the patients, they have achieved their dry body weight, but still they can have effusions which are quite resistant. So in these situations, we usually do pleurodesis. What is your experience, Tofal, in patients who have underlying renal disease and effusions?
But obviously, Talha, very good points you have raised. Obviously, it is a where we work is a resource-heavy country where every second or third hospital has got medical thoracoscopy. But I know, I don't know the figures, but maybe in whole Punjab, you may not have 4 or 5 centers doing medical thoracoscopy, and medical thoracoscopy is underutilized. As far as when it comes to TB in Pakistani setting, really, TB should be considered in almost every patient who comes with a fusion and they are not getting better, but treatment of the underlying supposed cause of these patients. Renal failure patients are different, really. I mean, usually they are at risk of bleeding and infection more and more. We don't want to touch the pleural space again and again. And hemodialysis patients, usually we liaise with our nephrology colleagues to improve the to take a bit more fluid out, etc., etc. But I totally agree that dual pathology should always be considered in those patients where it becomes refractory to the treatment of the underlying cause and keeps on recurring. And I know you have got excellent thoracoscopy service in Lahore, and thank you very much for that.
Absolutely,
thank you very much. Really elaborative and informative. And one more, point which you elaborated in your talk is out of proportional dyspnea in transudative effusion, especially relevant with the nephrotic syndrome and CCF. You must consider PE because at times the superadded PE can confuse the lab picture of effusion as well as the clinical picture. Absolutely. So this is very important.
I agree.
Thank you very much, sir. Again, thank you very much.
Thank you very much, Dr. Tofal, for an excellent talk. Really enjoyed this session. I hope everybody here agree with me. Now we are heading towards the last, toward end of our session. I'll take comments from a few of the participants, a couple really, before we end the session. First of all, I would love to invite Professor Khalid Waheed, who is the professor and head of pulmonology department at Lahore General Hospital, and also he's the vice president of Pakistan Chest Society, Punjab. So please, Dr. Khalid Waheed, if you give us a few comments in this session. Thank you.
Thank you very much for inviting me to talk. First of all, I would like to thank Professor Ayaz Mahmood, VC King Edward Medical University, and Professor Jawad Ansari, who is President of Pakistan Chest Society presently, for giving their very precious time to this webinar. By their presence, it was really very important to have them. And then I would like definitely to thank the chairs in the first session, Professor Saadia, Ashraf, and Dr. I think, I'm forward the name of second chair. And in the second session, Professor Talha and of course, Professor Ayaz, they took the time from this busy schedule and they were present on this webinar. Very importantly, the speakers, of course, all the four talks were full of loaded with the knowledge. And in first session, two of the speakers talked very nicely on empyema, infections in the pleura, and spontaneous benign pneumothorax. Dr. Beenish, they were excellent talks. And in the second section, of course, Dr. Tufail, who talked very nicely on very common, reasons of the pleural effusions, and Dr. Jurgen on malignant pleural effusion. We learned a lot, many things on these, and I'm really very thankful to the organizers for giving Pakistan Chest Society and the members of the Pakistan Chest Society to attend this webinar. I would especially thank Professor Tufail, who collaborated with me and took for this webinar. I think this is a very important way of learning and teaching, both for the Pakistani, doctors. So at the end, I'd like to say thank you very much, all the participants, and thank you, Dr. Abdullah and Dr. Asif, who were the host of this, webinar. And the last, I would like to thank KEMCA for allowing us to attend this webinar. Thank you, Dr. Tufail. Thank you very much all.
Thank you. Thank you very much for your kind remarks, Professor Khalid Waheed. Next, if I can invite our CPD lead for KEMCA UK, Dr. Athar Saeed, who is the gastroenterology consultant and our executive member of KEMCA UK committee as well. Please, if you can share your remarks with us.
Thank you, Takir. I hope that you can hear me well. The connection here is not all that good. I used to work as a young doctor in a small hospital in the early 1990s. At that time, the British Thoracic Society guidelines had just come out regarding the aspiration of a spontaneous pneumothorax and the possibility of discharging those patients home. So I remember I did precisely that in the A&E department and wanted to discharge patients home. But the evidence had not traveled so far at that time, and there was considerable distress among my seniors. So this is what I call a corona dividend, that Zoom is so common now that the evidence and the best practice travels very, very quickly across continents. It was a pleasure to hear all those learned speakers. I must especially thank Professor Mahmood Ayaz, who's been very helpful and very cooperative and is trying his best to improve learning opportunities at the King Edward Medical University. And in the end, rather shamelessly, I would want to advertise our upcoming big event in December, which is the Universal Healthcare Seminar, hopefully on 19th of December at the King Edward Medical University. Thank you, Takir, and thank you, everybody.
Thank you very much, Dr. Athar Saeed. Now, if I can request Dr. Tufail, who was the pioneer of this session, if you can kindly conclude the session.
Thank you very much, Toki. So what I can say is what a wonderful session, really. I'm really thankful to Professor Najib, Rahman, and Jurgen and Beenish. I know how difficult it is to find time on a Sunday afternoon in the UK. Really grateful and much appreciated for share of knowledge with our colleagues in Pakistan. So thank you very much, everyone, for attending, and thank you very much to the organizers.
Thank you very much, everybody. And Professor Mahmood, do you have any final comments before we start?
Yeah, I've been in the session for the last, so many minutes, and I think that it was a wonderful session. And I'm very grateful to KEMCA UK because they are holding these sessions very regularly. And I'm very eagerly looking forward to meet all of you on the 19th of December. And I listened very carefully. I told you that I had a great interest in thoracic surgery. So I listened to each and every talk very carefully, and it was very informative. I would really like to thank Professor Saadia, Ashraf, Dr. Badar, Najib, Rahman, Beenish, Talha, Salman, and Jurgen, and Tufail, everybody, because you've all done a wonderful job. It was worth listening to. And as I told you that I not only want to improve the academics of King Edward Medical University, but at the same time, I also want to improve my own academics. So this was very a good learning session for me. I just learned a few tips and tricks how to actually manage benign pleural effusions and malignant pleural effusions, how to actually plug in the holes in the pneumothorax. So it was wonderful. Thank you very much.
Thank you very much. And hopefully we will be editing this recording of this webinar, and we'll put on our YouTube channel, and we'll share it for people who have not able to attend. Thank you very much, everybody. And we will be finishing our session. Thank you very much.
Thank you.
Thank you.